Our Heavenly Father, we thank you so much for this platform that you enabled us to attend. We thank you for granting us the talent to be instruments of your healing as surgeons. We pray that we are able to come together in unison to provide healing care to your people. We pray that you straighten the paths of those who are on their way, grant them journey mercies as we convene in this great gesture. We pray all this through Jesus Christ our Lord. Amen.
Thank you. Thank you so much. We can have our seats. So we're going to have a speech from the chair of the scientific committee, Dr. Christine Namgenyi. Please.
I'm filled with joy, and I think that's why you see this big smile. Thank you so much to each single one of you, protocol observed. I'm overjoyed that you're actually here. Please, thank you for keeping the time. Apologies for this late start. I officially welcome you to the 2025 ASAO Annual Scientific Conference, Surgical Landscape Exhibition, the Charazi Memorial Lecture, an AGM, and a gala. So please don't leave before any of those events end. This year's conference theme is to focus on surgical education, and this is to pivot towards safe surgical care in Uganda. I'm really sorry. I'll not say much. I know I have another avenue when I will speak to you. So please welcome. Let's have tea.
Thank you. Thank you, Dr. Christine. We're going to have welcome remarks from Professor Moses Galukande, who is the president of the Association of Surgeons of Uganda. Professor, you're welcome.
Good morning, ladies and gentlemen. Our guests from across the borders, thank you for making the time to be with us here. We'll have a chance to mention you by name, but you are very welcome. And thank you very much for all the other Ugandan delegates for braving the morning flash floods and being here. It's an exciting time for us to be able to do this again. We have maybe three major things that the Association of Surgeons does, and one of them is this. We do what we call a national surgical exhibition, and there's a tent out there. So we get the different individuals and institutions that are ready to showcase what they do. One of the challenges we have in our communities or country is low confidence in public services. And surgery is not exempt. So surgical services People may not have a lot of confidence, and I think it's partly because we don't do a good job of telling people what we do. We wait for them to come to hospital, and we do the treatments and so on, but we don't make any noise about it. And for that matter, it's the bad news that moves and dominates. So one of the purposes for the surgical exhibition is to show the country what happens. And the last one, some people were surprised that actually a lot happens in those four walls of what we do. So this time around, we may have about, I think, between 20 and 30 exhibitors, and you'll be welcome to walk there and see what is done. Then the scientific conference, it's a great opportunity for us to do a number of things. We want to show scientifically what we're doing, what we hope to do, but also inspire the next generation that's coming. Again, this kind of thing deals with some of the challenges we have in the whole discipline of surgery, which is to encourage surgeons to write and publish and present. In many disciplines, I think surgery lags behind. We are more, I think, attuned to removing lumps and fixing broken things, but we tend to be a bit shy about going in public and say what we do. And this is important. It's an important thing to do. We must do it. So this is a critical platform for that to happen. Earlier on, I was talking with the president-elect of the association, and we said, you know what, again, some of the challenges people might face is the costs for coming to this conference are high, but guess what? This is maybe the only international, locally designed international conference that you'll be able to access at $100. If you wait to go to London for one, you may need to fork out some pounds, yeah? So we encourage people to take this opportunity to do this. And of course, now that you're here, you are the converted. But of course, this message goes out to all the medical schools in the country that this is an important platform that happens consistently every year, and they should take advantage of this. So looking forward to these days, these couple of days, to listen to presentations, discussions, but also networking. Networking both here and with the people who come from out. Last but not least, at least for now, is to thank the teams that have worked tirelessly for many months to make this happen. Like you may appreciate, it's not a walk in the park to pull off the things, especially with limited resources. And when people also have a day job, this thing demands lots and lots of hours. So really appreciate the team that is worked very hard. Again, we'll have an opportunity to mention names, but definitely the Secretariat of ASO, the Council of ASO have done a good job. So you people, you voted well. So wish you great deliberations, networking, and also enjoy the exhibition. Thank you very much.
Thank you so much, Professor Moses Galukande, the President of the Association of Surgeons of Uganda, for those welcome remarks. So at this moment, I want to invite you for a break tea. The breakfast is on my right. So you can go to any of those tables and enjoy the breakfast. Thank you. continue with today's program. So when we were here early in the morning, we were still quite few, but now we have slightly more numbers, more people who have joined us. So we are going to do some introductions, then so that we can get to know each other, so that we don't look strangers to each other. Do we have a mobile microphone, please? Help us, Susan. Thank you. The delegates having tea, kindly carry it to your tables so that we can proceed. Self-introductions. Yeah. Self-introductions, yes. Thank you.
Hello, I'm Jennifer Rickard. I'm a trauma and critical care surgeon from the University of Minnesota.
Hi, I'm Kara. I am a general surgery resident from the U.S., currently living and working in Mbarara with Dr. Felix and their pediatric surgery team.
Hi, I'm Julia. I'm a general surgery resident from the University of Minnesota, working with the pediatric surgery team at Malago.
Hello, I'm Dr. Rosa Leño, a plastic surgeon and the president for the Plastic Surgery Society of Uganda.
Good afternoon, Fred Biso, ENT surgeon, Malago Hospital.
Olivia Chituka, upper GI and HPB surgeon, Mulago Hospital, and lecturer with Makerere University College of Health Sciences.
Good afternoon, I'm Olive Kobsinje. Thank you.
Good afternoon, Jacqueline Mabujano, general surgeon.
Good afternoon, I'm Jaliat Namoya. I work with Bukedde.
Good afternoon, Dr. Sime Frank, urologist, transplant surgeon, immediate past president, Association of Surgeons of Uganda. I'm glad to be here on time.
It's afternoon. Good afternoon, everyone. It's a pleasure for me to be here. I'm an anesthesiologist in a house full of lots of surgeons. My name is Mary Nabkenya. I'm the president of the Association of Anesthesiologists of Uganda.
Joshua Semambo, working with UBC.
Good afternoon, Olivia Nachitende, CBS.
Good afternoon, Barbara Nyaits, journalist working with Nation Media Group Uganda. Thank you.
Good afternoon. My name is Eva Snimsima. I'm a medical doctor.
Good afternoon. My name is Ivan Tsebeni, and I'm a writer with a New Vision.
Good afternoon. My name is Fred Kayongo. I work with Uganda Radio Network.
Good afternoon. My name is Dr. Jamal Ahmed, surgical resident, Makerere University.
Good afternoon. I'm Dr. Luede Aliba Flavia Ojok. I'm a general surgeon from Soroti University.
Good afternoon. My name is Arach Patricia. I'm a general surgeon working with Mulago.
Kuigwa Mwanze, general surgery resident in Makerere University.
Kabyanga Lois Kime, general surgery resident, Makerere University.
Bwapus John Robert, general surgery resident, Makerere University.
Good morning, everyone. I'm Dr. Muge Noren Priscilla, surgical resident at Makerere University, finalist.
Good morning, everyone. I'm called Oscar Ogwang, a general surgery resident at Makerere University.
Good afternoon, everyone. My name is Ario Joseph. I'm a general surgery resident, Makerere University.
Good afternoon, Hans Lokale. I work in Moroto Regional Referral as a general surgeon.
Good afternoon. I'm Susan Katsime, a theatre nurse, International Hospital, Kampala.
Good afternoon, members. I'm called Dennis Kato. I work with Big Media.
Praise God and good afternoon. I'm a journalist, Ben Musanje, attached to Radio Sapiensia.
My name is Anne Shikanda Wesonga, pediatric surgeon, Mulago Hospital.
Good afternoon. I'm Nick Arthur, general surgery resident, Cavalry University.
Good afternoon. I'm Tumasige Charles, general surgery resident, Cavalry University.
Good afternoon. I'm Rona Kwikiriza, fourth year medical student, Cavalry University.
Good afternoon, everyone. My name is James Sampumza. I'm a fifth year medical student, Cavalry University, and also the chairperson of the Cavalry University Surgical Society.
Good afternoon, everyone. My name is Deborah Chemtai Mangusho. I'm a fifth year medical student, Makerere University.
Good afternoon, everyone. My name is Jarila Nasos. I'm a neurosurgical resident, COSEXA.
Good afternoon. Robert Maserek is my name, general surgeon and urologist, Naguru Hospital.
Good afternoon, colleagues. My name is Kayongo James, medical representative from Troika Pharma, the makers of Dynapa injection and Dynapa tablet.
Good afternoon, everyone. My name is Joseph Bisaso. I work with Bulamu Healthcare as the field operations manager. Thank you.
Good afternoon, everyone. I'm Dr. Mokuye Andrew, Director Health System Strengthening, Bulamu Healthcare. Bulamu partners with us to do surgical camps in different regions of the country.
Edward Kakungulu is my name. I'm the president-elect of the Association of Surgeons of Uganda. We are going to go into the next session, and I would like to invite the chairs of that session, Professor Frank Asimwe, who is a consultant urologist at Mulago National Specialized Hospital, and Dr. Mary Nabukenya, the president of the Anesthesiologists Association of Uganda. You're welcome.
Good afternoon once again. I thank all of us for making it. I would like us to adjust our watches. We can vote, you know, Ugandans like voting. You can either put it back to 8 or 9, but whichever you choose, the session has started. I would like to welcome our guests from far and beyond, and also recognize our local participants, our delegates. We've got a strong presence of the SHOs. You are most welcome. Without much ado, this session we're talking about the National Surgical Obstetric and Anesthesia Plan. If you want to move surgery to any level, you must bind these three groups of players: the surgeons, the obstetricians, and most importantly, the anesthesiologists. Let me take this opportunity to welcome my colleague, Dr. Mary, who is going to give some few introductory remarks on what this plan is, and then we'll be calling up a panel here on the, at the front, and we'll answer some questions on this subject. Dr. Mary, you're welcome.
Thank you very much, Prof. Good afternoon, everyone, or good morning, since we've adjusted our clocks. So, when you're in a surgeon's meeting, you think everything is about surgery, and everyone should know about surgery. Unfortunately, that's not the case when you think about global health, right? There's a lot of funding in global health. But we all know that for the most part, if you just think about Uganda, for the most part, when you think about Global Fund, when you think about all the money that we've recently lost because of recent developments in American politics, it goes to malaria, TB, and HIV, right? And yet, if you look at the statistics, a few years ago, it was shown that post-operative deaths contribute to, they're the third highest causes of surgical disease globally, third highest, right? And yet the money is not coming to surgery. So why are we talking about the NSOPs, the National Surgical Obstetrics and Anesthesia Plans? The year 2015 was a landmark year for surgery, for global surgery. Why? Two big things happened. One, at the World Health Assembly that year, one of our distinguished speakers and panelists today passed a motion to get surgery to be recognized on the world stage. And that year, a resolution was passed to strengthen emergency and essential surgical care and anesthesia to become part of universal health care, universal healthcare coverage. So that was one big thing that happened for surgery on the global stage. The other thing that happened was the Lancet Commission on Global Surgery, which was passed that year, and what it highlighted was 5 big things. That 5 billion people out of 7 billion in the world lack access to to safe surgical care. As you can imagine, majority of those 5 billion are people that are like us in low and middle income countries, okay? And then 143 million additional surgical procedures are required or are needed every year to save lives, okay? And then 33 million people in the world experience catastrophic expenditures because they are seeking health care. Of course, the burden of this comes to people that are in low and middle income countries. And the conclusion of all of this was surgery is an indivisible and indispensable part of universal healthcare coverage. So in order for us to achieve universal health coverage, we must take care of surgery, okay? And so now from the Lancet Commission on Global Surgery, a few countries led by Zambia went ahead to develop their national surgical obstetrics and anesthesia plans. Several countries to date have developed theirs, and Uganda started their journey. We're going to have one of our panelists is one of the people who started that process. And what we hope will come out of this is that we will have a resolution that can go to Parliament, that the Ministry of Health is already in charge of, but we need something more concrete. We need a commissioner in charge of just surgical care. We need everyone to understand more that surgery and surgical care, and when I say surgical, plug in surgery, obstetrics, anesthesia, trauma, everything falls under that umbrella. All those things are important and we need someone to fight for it. So without further ado, I will hand over to Professor Asimwe to introduce our guests, our speakers.
Thank you very much, Dr. Mary, for that introduction to this pertinent topic. Our panelists today will be including the following: Professor Emmanuel Malambo Masaka, who is a global health surgical consultant from Zambia. He's a researcher, he's an academician, and an experienced clinician. He's a founding executive director of the South African Development Communities University of Witwatersrand, best regional hub and collaboration center for surgical healthcare improvement, and its SPOC. He's the chair of SADC's Technical Experts Working Group on Surgical Health, and he has graced us with his presence. You're most welcome, Dr. Makasa. You are allowed to call him Dr. Mukasa. And he has visited the Sawa surgeon, he has agreed. Also on our panel is Professor Ahmed Ogwell from Kenya. He's also a public health expert and senior advisor on global health at the UN founded, covering a wide portfolio. He brings to us a 3-decade experience in public health. His bio is big. He has been head of the African CDC. Most importantly, he led the African CDC during the turbulent time of COVID. You are most welcome, Professor Ahmed. Also on the panel is our very own Professor Moses Garukande, who is the president of the Association of Surgeons of Uganda. He's the chair of surgery at the Makerere University College of Health Sciences, based in Mulago. You're most welcome. Joining us online, I don't know whether we are going to be able to get the connection. will be Mrs. Nkeiruka Obi, who is the Vice President and Regional Director for Smile Africa, Smile Train. She's a Senior Development Specialist with also 3-decade experience in banking and social enterprise. Currently, she's the Vice President and Regional Director of Africa at Smile Train. We are going to tap into her expertise as well. Most welcome, Mrs. Obi. The technical team, we have her online. The other experts are still trying to make it through the jam, and they will join us. I will ask Dr. Mary to take on some of the questions to the panelists.
What was the original vision, and over the years, how do you think this has evolved?
Thank you very much for that question. I've had the opportunity and privilege in the past years to interrogate the surgical landscape in Uganda, participated in a number of studies and surveys in the country, and I think in the early, maybe from as early as 2010, we did a national survey really interrogating surgical access. And not very different from many other countries in the region. There's very limited access to surgical care in Uganda. There's a low density of surgeons per population. There are challenges with the infrastructure, and so on and so forth. But in one of the studies we did, it was a national study. We found at that moment, I think it was 2016, we found that 4 million, close to 4 million Ugandans needed an aspect of surgical intervention, but they couldn't get it. 4 million, and at that time the population, maybe that could have been maybe 20%. And that was an enormous, unbelievable number. And as we did this with many of my colleagues, we thought it just shouldn't stop at a publication. We should rally some action. And of course, many other people had made those calls. So that's the way, at that moment, we were energized to move this forward. And like it's been published and discussed elsewhere, surgery tends to be, I think the word was neglected stepchild. There are many initiatives in the country, many things are being pushed for. Of course, infectious diseases top the list. But when it comes to surgery, there isn't as much attention for many reasons. And then when we try to make the case, we are told that we're not advocating enough. We're not making enough noise. So I guess this is one of the opportunities we have to make that noise. And definitely when NSOP idea was developed, we thought it might be a good framework and platform to get it accepted by our country, our Minister of Health, so that we have, if you like, a contract to address surgical access, which means many things, but including safe surgery, safe anesthesia, safe obstetrics. So I guess that's the background of the energy that developed for this. And how has it evolved? We're kind of unfortunate. The DG is not here today, but I received a call that they'll try to make it tomorrow. At every opportunity, we shall make the noise. But the minister, I think, has understood that this is important, but I think we need to get it to its rightful conclusion. A form of contract. I don't know what other name there is for that. An act of parliament or something like that. A vote from the Minister of Finance that this should be prioritized. Thank you.
Thank you very much. An act of parliament sounds like something that would be that would really push us forward. All right, we'll move to the next panelist.
Yes, Professor Emmanuel, we thank you for making the journey to us. We would want you to, first of all, share with us your experience in Zambia so that we see what we can learn. And then basing on that, you tell us what are some of the things, the challenges you've met and the progress you've made from which Uganda can learn from the Zambian experience in implementing the NSOPs.
Thank you so much. I would like to thank the Society for inviting me, and of course the partners for making it possible for me to show up here. Yes, I have worked in this space for some time, and I have been not only supporting the Republic of Zambia, but the all 16 Southern Africa Development Community member states. And it's a lot of material. I hope I can compact it and give you. So first of all, the Zambian experience, after we passed the resolution 6815 in Geneva, obviously we did that for ourselves because there was a need that we saw primarily in the Republic of Zambia, and of course all the sponsoring member states. Uganda was one of them, the Republic of Kenya, and basically all the sub-Saharan countries strongly supported and were co-sponsors of the resolution 6815. This came out of the need that we had, and we knew that we, like the chair has just said, that the gap was huge, especially for those of us who were working in the health sector. I'm an orthopedic and trauma surgeon, and so from my training and my practice, it was very clear that surgical services were not available to everybody who needed them. And we did not have any guiding policy, so to say, or commitment, political commitment that we could use anywhere in any platform, intergovernmental platform. And so that's why we tabled this issue at the United Nations in Geneva. Now, once we got the resolution in 2015, yeah, in the Republic of Zambia, then we moved to develop our initial National Surgical Obstetric and Anesthesia Plan. Now, the template to develop the NSOP, or even the acronym NSOP, comes from the Lancet Commission. That also was one of the products that came out of the Lancet Commission on Global Surgery. I happened to be a commissioner of the Lancet Commission in its last meeting in Bellagio. At the time, we had already gotten through the executive board of WHO, so we already had consensus and we were going to have a resolution. And for me, as a diplomat for my country, I was already looking at what we could use to actually do something about the commitment we were going to get. And so being part of the Lancet Commission, that's where we got the template on how we could start, because there was nobody who had any framework, theoretical or practical, that we could use. And so in 2017, we launched our first National Surgical Obstetric Anesthesia Plan, which was running from 2017 to 2021. Now, there were challenges that we have learned that I think I was asked, and I'll keep giving the experiences and challenges not in any specific order, so please bear with me. The first one was that the launch of the Zambian policy was done in Geneva, not in Lusaka. That already is a problem, because then you are launching and disseminating a product to people who are not the custodians, so to say. Dissemination at country level was not so good, because again, as you know, surgery is not something that only affects people working in the health sector or surgeons or obstetricians and anesthetists. It affects the whole community. And so dissemination must be to the whole community. And so in Lusaka, we only disseminated in professional associations. We spoke to the obstetricians, the anesthetists, the surgeons, and that was it. Transport and Communication Ministry never knew. Finance, you know, all the key sectors, even the population. So the dissemination was bad. It was not good. So the document basically stayed in Lusaka. Even in the district hospital, some people did not know about its existence. So that's the problem. The next thing that we detected very early was the way it was developed. Obviously, being the first document, we developed that document in 6 months with support from the PGSSC from Harvard and, of course, the local stakeholders. But again, it was not as inclusive as it should have been. Because of lack of inclusion, which affected, you know, uptake and dissemination and also buy-in. For example, the nurses refused to have anything to do with the NSOP because they said it's surgical, obstetric. You know, we like to, I don't know why we do that. But anyway, so they say that nursing is not one of the things mentioned there, so it's nothing to do with us. So there was complete no buy-in from our perioperative nursing colleagues, which again was a problem. The third thing is the governance. And okay, maybe here I should also give the solution that we are looking at. So to avoid that, for example, in the revised version of the NSOP, in terms of inclusion, we have tried to make the team much, much more broader. So everybody is involved, starting from the paramedics, the non-clinician physicians, the community, the disabled, the police, road traffic, Ministry of Finance. Every stakeholder has been included. And we have changed the name because, again, the problem also, like we said, if you look at the systems in many countries, you may have some things that can function in Kampala or in Nairobi, but the rural areas really don't have anything. And the drive, why we try to develop our national surgical plans or surgical healthcare plans, is first of all to cover those that are marginalized the most, who are the rural community, those who are at the lower levels of the system. So if we're going to make surgery as the vehicle to achieve universal health coverage, which uses the primary healthcare approach, then we must customize everything that we're doing to fit the narrative and the approach. Meaning we must close the gaps at the lower levels of care, the primary health care, and the district. And so to be able to do that, we've changed the name in Zambia and we're calling it the National Perioperative Healthcare Strategy. Perioperative, meaning we want to cover the preoperative stuff, we want to cover the intraoperative stuff, and we want to cover the postoperative stuff. And pre and post are always usually in the community. That also, the naming of the strategy like that also makes it more inclusive. So we're not having surgeons fighting anesthetists like they like to do, or the nurses joining the fight. No, we're not going to have any of that. So it's not specific to any group of professionals, and it also fits in with the narrative and the other visions and other policies that are already in place. So that's what we did. Like I said, I could say a lot, so I'm going to try to summarize. So the other thing was funding. There was no clear budget lines on how we're going to mobilize resources to implement the policy. Normally, we must leverage funds from existing programs because surgery is not something that sits in one place. There is surgery in pediatrics, there's surgery in obs and gyne, there's surgery in internal medicine, there's surgery everywhere. So we must be able to leverage funds that are already in these specific programs to support the surgical component within those programs. If you want to talk cancer care, cancer has a lot of money, But before you know what cancer it is, you must take a biopsy. Taking a biopsy is a surgical procedure. So the cancer program itself must bring the money that are needed to ensure that we can do biopsies and do early detection instead of the detection only being done in Kampala. So funding was a problem, how we mobilize the resources and also new resources. Governance, like I said, was a problem. A health system needs governance. And for the first time, surgery or the NSOP is cross-cutting. It's not a traditional policy or program that is vertical. So malaria control program starts from the Ministry of Health all the way to the patient in the community. And each person knows what to do. But surgery is not like that, like I said. It is the first policy after the SDGs that is cross-cutting. So how do you coordinate a cross-cutting policy when you have structures of governance that are vertical? Again, so that was a problem that we're trying to sort out. And then progress, a little bit on the progress. So like I said, we partially, almost maybe 20% in my estimate of implementation was achieved because it was mostly on the health workforce development. So we have done a lot of health workforce development, both at undergrad, especially at undergrad, and postgrad. In that, we have expanded the COSEXA training program. We have the MED programs in more than one university. And we've also established a mirror of the COSEXA program, which is called STP at country level. Now, like I said, the undergrad program is also covering a lot of professionals. What is lacking now is the quality, because as you know, if you expand very quickly, you lose the quality aspect, which is really an issue. The last 2 years or 3 of the implementation were derailed by the COVID-19 pandemic. As you saw, everything went to COVID and nothing really kicked after that. And yeah, maybe I'll end there. Like I said, there's a lot of things I can talk about, but just for the sake of time, we can discuss with specific people who want more details on this after. Yeah.
Thank you very much. Obviously, we are going to have to engage you beyond this panel. So to our next panelist, Dr. Ogwell, thinking about Uganda and the fact that we are still in our process to have our plan, how can we position ourselves to attract international funding and maybe technical support to help us with the implementation of our plan once we have it?
Thank you and good morning. I think we were told to adjust our watches, so it's good morning to those of us who are here. Let me first say that it's really good to see that different cadres within the health sector are now coming together to try and think around a problem from a very systematic way, rather than the different cadres fighting each other, which has and continues to be, I think, a very big challenge within the health sector. Having said that, I see that we are discussing, there's a conversation about a plan. And in health systems, when you reach a plan, it means that you've covered all the other things. Then you have a plan, unless the plan is to develop the other things. And for me, the other things are 3 very important steps. One is policy. And policy can either be through legislation or it can be through the regular policy making, strategizing, strategy development, etc. So is there a policy? This is not very clear to me in the Ugandan context, especially when we are talking about this very critical interface where surgery brings together many different aspects. So this is one. Second, very important part of this discussion as we develop the plan is resources. You talked about funding. I always run away from discussing money because money discussion is very complicated when you don't have the core of what you want to fund. And I always talk about resources because many times we have everything else except the money, and yet everything else makes up maybe 90% of what we want. And then we focus so much on the money that we forget about the 90%, which is knowledge, it is infrastructure, it is institutions, it is local acceptance by the different groups, whether it's communities, it's politicians, or our technocrats within government. So looking at it from resources will be more comprehensive. And I'll explain in a minute how that becomes comprehensive. This is second. And then third is, although we talk about communities, let's see communities not as our parents, aunties, and cousins in the village. Communities include those of us who are out here at policy-making level. All of us are a community depending on what we are talking about, and when you're talking about surgery in general, that becomes important. So these three need to be part of the discussion for resourcing, either development or implementation of that plan. So stepping back and looking at what we've been doing at the continental and increasingly now at the global level. At the global level, we already have the policy that has been put in place. The World Health Assembly pronounced itself, and we have a document on which to base our discussions when it comes to localizing the issues. At the continental level, there are two important things that we've tried to do, particularly during introduction. It is confidence in our expertise, not just as Ugandans, but as Africans. Do we have the confidence of presenting ourselves to theater when we know that the anesthetist, the nurse, the surgeon, they are all Ugandans, they are all African? Do we have that confidence? And if we do, then it means we can support the process of expanding. Good morning, PS. We can then support the process of expanding capacity within our different institutions and facilities. So that confidence is what we need to work on. That are we providing the public with enough information to be confident that we as Africans, we as Ugandans, can be able to take care of their surgical needs when the time comes, when they need it. So that is one very important area. The second that we've been trying to do at the continental level is how do we ensure that the different plans, the different policies, and I'm glad that Emmanuel and team have been working within the SADC region, how do we ensure that those plans, those strategies, those policies are actually speaking to each other, so that you don't get a plan in one country or a strategy in one country that speaks a very different language from the plan, strategy, or policy in another country. As soon as they start speaking different languages, then it means harmonizing becomes that much more difficult in providing a seamless support across different countries, especially here on the continent of Africa. So we then came up with what we thought was a very good idea, the new public health order. And two aspects of the new public health order for the continent are very important to the conversation that we are having today. One is local expertise, which I touched on a little bit. And second and more important is local resources, including money. And as I said, we tend to focus very much on the 10%, which is the actual money, instead of the 90%, which is different types of resources. And we have all those different types of resources within our own countries, within the continent. Now, when we look at the money aspect, which is really what the question was, let me focus on the 10% now. When you look at the money aspect and considering the happenings over the last 3 or so months, well, a little bit less, but it has been since January something, 20th, we tend to believe, indeed, we tend to focus on money that comes from outside of the borders of the continent of Africa. And it is not a lot. In the larger scale of things, it is not a lot. while we do have money within the continent of Africa that if it was readjusted to focus on some key aspects of the health systems, including the surgical initiative that we are discussing now, it can be able to give us that good first step. Then other friends and partners can be able to continue to make that support. The reason why that first amount is important is because it sets the direction. And as many of us have heard, direction is more important than speed. Many times the money that we receive from outside comes with speed. The explanation for that is that it gives you specific things that you can be able to do, not necessarily what is your priority. It will tell you the indicators that need to be met for that money to have achieved its goals. Is the direction the one that we want? Sometimes it is not. Is the speed the one that we want? Sometimes it is not. So my encouragement will be that although there are resources at the global stage, and we can be able to put ourselves in touch with those that have the resources, it is more critical in my view to have the resources being raised locally. We have private sector within our own countries. We have high net worth individuals who we can convince to invest in communities in which they live in. We have also different aspects that can be turned away from money into expertise. Someone who can do a proposal and pro bono is not paid. Someone who can be able to build the capacities of others and is not paid. All that, when you monetize it, becomes a lot. But let's start with what can we be able to raise locally? That way we set a direction. And when we get then the resources from outside of the country, they fit within a direction that we've already set. If we wait to do that with the money that has come from outside, sometimes it is another direction apart from the one that we really, really want. But for the moderators, for me, the big question is when we are talking about a plan, do we already have the policy in place? When we are talking about a plan, are we doing it in conjunction and collaboration with others? I'm glad that the SADC colleagues are here, so that they can be able, those plans can speak to each other and they become adaptable, and the capacity that we have in one country can actually support another country as you develop your plan and as you start the implementation. Resources from outside of the continent are possible, but I prefer that resources from within the continent are used first to set the direction, so that anything else coming to support finds a direction that is a priority for Uganda, for the continent, and in that way, when speed comes, we are all aimed in the right space. Thank you very much.
Thank you very much, Professor Ahmed. A lot of experience and perspective. Would like to welcome our peers. Thank you for making it again and again. We are honored. We'll be asking you a few questions, but we just want to update you. We're talking about the National Surgical, Obstetric and Anesthetic Plan. Talking about policy, funding, and the rest of the aspects to that. I'm also informed that our online guest speaker is on. Is that correct? Madam Oboy, are you online? The technical team, do we have her online? No, okay, it's a thumbs down. All right, just Professor Garukande, how can professional associations like ASO and those of the concerned associations, the obstetricians, the anesthesiologists, how can they play a role to ensure that the NSOPs is not just a policy, but it comes to be rolled into action?
Thank you very much for that question. To just re-echo one of the points I made earlier is, should I call it the accusation, that surgeons were not doing a good job of advocating for our needs, advocating for our luck, and showcasing what we do. I think it's a great thing to have associations, and so we're getting together and make a stronger voice and synergies. And I think then we should use associations to articulate these needs and make our way to the table where these things are discussed. And not only view our importance in only the operating room. I think that's the first call, and definitely then within the associations we should be maybe more organized to make this happen. But having said that, creating platforms like we're doing right now, I think is in the right direction. And we really appreciate the collaboration and support from the Minister of Health, because those are the strongest partners we have, and to make them, we know that they are aware, but to make them more aware and to make more noise and to put more pressure, if I may use that word, to make this happen. But the other aspect, which is also our obligation because of the competences we have, is to generate the evidence. To generate the evidence through the work we do, research, and so on and so forth. To generate the evidence that this works, to generate the evidence of the consequences of not doing things. And I think that evidence is critical. Just two last things on that. One time I had a chance to speak to one of the subcommittees of Parliament on health, and there's a point we're making, and they told us that they didn't know anything at all, anything about it. And then it reminded me that maybe the onus was on us to generate this information and make it accessible and usable. That is the evidence that I'm talking about. And the last bit of that is, sometimes I envy the way other disciplines articulate their needs. And one of the things that was very impressive was when we were doing mass circumcisions in the country, it was articulated very well that a circumcision, which at that moment costed about $100, would avert many years of illness, many years of spending. So you spend $100 and you avert 8,000. And when that kind of thing is presented to anyone who holds the purse of resources, it's a no-brainer to spend 100 so that you save 8,000. So we need to speak and generate the evidence that compels action and is convincing. Thank you.
Prof is an advocate for advocacy. I think we all need to, in our little spaces, each one of us needs to shout so that people know, because again, we're speaking in this room, we are all surgeons, we know what we are talking about, but outside of here, people don't understand what we are going on about. So now we are honored to have a permanent secretary for the Ministry of Health here. And I'm hoping you've had a breather. So we'll ask our first question. So when we think about the National Surgical Obstetrics and Anesthesia Plan, we'll probably call it something else by the time we have it. What specific commitments can we hope to get from the ministry regarding the financing and integrating of the plan within the ministry's health strategy or the country's health strategy?
I had one. First of all, thank you so much for inviting me. I bring my apologies for coming late. Nonetheless, I'm here. Let me begin with a question. What can Ministry of Health do? First of all, in this space, we have three important players. The first one is you. Individual, association, and collective as a profession. I know that when we are being trained, we don't know how to blow our trumpet. Normally, we just, you learn how to go in theater and operate and come out, and that's it. So the patient that you work on is the only one who knows you. And outside the boundaries of the hospital, very little is known. And I know we can't be what we are not. I know that you may not learn to do the advocacy of civil society later. You may not learn that because the training conscued you into another direction. However, I know that there are pathways that you can implement to make your work known, appreciated, and supported. So first is you, and you have to come together. And I wanted to talk, and I'm glad that what I was thinking about is what I just found on the table here being discussed. That is forming really the main message I wanted to talk about today. Competition versus complementarity. Competition versus complementarity. We are all struggling in our little spaces because we don't have resources, and each one goes and sets up this tiny thing, or this one is working here, you are in silos. There is strength in unity, not just as an association to come together and talk about science, but also investment. In other countries, the associations come together and invest together. When they invest together, you have like a whole complex, like surgeons complex, and everyone who wants surgical services actually on the private will go there and find all the brains of the country are in that place. And when you pull together your technical capacity, your connections, your experience, your resources, you tend to get a multiplier effect than if you are alone. So first, before I answer what Ministry of Health is going to do or what would want to do, is that we want to see the association that is united in purpose, on technical ground, on financial ground. If you have a voice, we can actually go and advocate for your funding. We have now different government initiatives that is running in the country. We have PDM, we have, they are giving, of course I know that PDM is meant for the other rural villagers down there, but it depends on how you package this information. We can knock at the door of the funders, World Bank, ADB, but success comes only to those that are united and organized. We don't just want to be organized in conferences, and once you get out of here, then each one goes in his or tiny small clinic that is ill-equipped and cannot make a big difference. So if you really want to see funding On a personal level now, I'm talking about personal, I'm not talking about now coming back to government, because government is government. They will provide what they have. They will not be able to provide what we don't have. I'm not going to pledge heaven on earth when really we don't have these resources. But on the personal level, on association level, on the technical level, you can actually form a very, very formidable force that we can reckon with. That can only be possible when there is coherent, when there is a focus, when you know exactly what you want to achieve. You may not get funders that will just come and throw money at, to you, because you're an association of surgeons, obstetricians. But we do believe that also there are some alternative health financing that we can look to together, supported by government, recommended by government. We go to and knock at the doors of World Bank or ADB or whatever, or Islamic Bank, whatever, whoever is there ready to fund. Because we have not tried that. No one has ventured into this. The last time I was talking to the private practitioners association, we agreed that they will send the proposal, and actually we went to the bank, and I believe if you ask some, I think there are some doctors that got funding through World Bank, especially the private sector doctors. So what can we do as government? One, would support that process of unification and strategic planning. We can work with you and come up with a very clear strategic plan, what you really want to achieve in the next 10 years, in the next 5 years. And then we look at the funding modalities. And then we engage. I can't promise that the money will be there automatically, but we engage. So that is what we can do. But the other area also, for you to be known, and because it's all about really blowing your trumpet. It's not just setting up infrastructure and all that, but it is also being known and you are able to create an impact in the community. I think what you did last year was, and the other years, I think the previous years, as association of the surgeon together with anesthesiologists and all other players, what you did to go out and offer pro bono services and operated over 2,000 people in the space of 1 week or just 10 days, it was a game changer. Up to now, they still talk about you, where you were. And I can assure you now, those that you interacted with, especially the leaders, they know exactly what you are, the capacity that you have, and if there is any support, I believe you'll get that support. And through that, then we can lobby the politicians who appropriate funds. Because we can say we need to fund private associations for them to be able to stand, to put minimal investment that can support them. And we can only achieve that when people know what you have done. And I believe that what you've been doing in the last 3 or 4 years is evident that now people are knowing. When I get invitation of ESAO, I come because I know what you are I know what you are doing. I know the amazing work that you have done. I associate with you more than I associate with the physicians where I belong. I associate actually with you, the surgeons and the obstetricians more, because for the work that you've been doing for the last few years is tangible, is transformative, is creating a very big impact. So we'll work with you, we are available. But you have to first have a plan. You have a strategy. What is your strategy? You think Ministry of Health will sit and do this for you? No. What is your strategy? You think Ministry of Health will sit and do this for you? No, we will not be able.
The ministry integrating the NSOPs into the existing broader Ministry of Health programs which are already running. I'd like to give a comment about that. National Surgical Obstetrics and Anesthesia Plan.
Can I have that? Can we have it? Can we have it? And definitely, at the moment we are concluding NDP4. It will be good actually the timing that those plans would come when we are concluding our NDP4, but still it would not be a problem. Even if NDP4 is done, we can integrate that in our strategic plan, the sector strategic plan, so that it feeds into the NDP4. So please, let us have it. We will definitely, I would invite you, you come and present that plan, and then when we are in the next budgeting, it becomes, you know, in government, you don't know the monster called government. Even if I really want to support you so much, but if it is in the work, it's not in the work plan. If it is not gone through that process of approval, appropriation, it will not be able to put any money there. But if we go through that and we make a presentation and we integrate that plan, why not? We would support. Thank you.
Thank you very much. PS, we are graced with Professor Ahmed Makasa from Zambia, who was actually a part of the inception of this NSOPs. We have also been blessed by the presence of Professor Ahmed from Kenya. They have already made some few presentations. We are continuing with the discussion. Professor Emmanuel, you've shared with us your experience both in Zambia and in a few other countries, especially in Southern Africa. How would you advise Uganda to balance the short-term wins and the long-term system strengthening in the execution of the NSOPs?
Thank you. First of all, I greet the PS and thank her for her presence. And just to echo what she has said is exactly what we have gone through in every country. And here already she presents the most opportune time, like she has said. If there is no policy alignment and integration, it's very difficult for anybody to move the needle forward. The short term, you have to try and work quickly to ensure that before everything is concluded or before the strategic plan is developed, this is done. Now, once that is done already, because it probably is going to be the first plan for Uganda, like we had the first plan for Zambia. Again, I didn't go into all the details of the challenges we had. It's almost impossible to implement countrywide a new policy plan that has just come up. So you must, as professionals, it's your responsibility, professionals and academic institutions, with very little, the government will provide the system, the district hospital or the provincial hospital, where you must do the initial implementation. The budget cost and like my colleague here said, the resources, the funding is only maybe 10%. The other resources are already in place. To do the initial implementation is minimal. It is actually something that even a grant can fund from an academic institution.
Why do you need an initial implementation? Because first of all, you need to generate the evidence and demonstrate the impact of how does investing or improving, perioperative care, I'll call it perioperative care. You can call it surgical, but I like to be politically correct now because it has to be integrated and inclusive. So how does improving perioperative care strengthen the health system? Government and everybody wants to strengthen the health system. How does improving perioperative care and ensuring access to safe surgery is there 24/7 help with health outcomes, not only for the surgical patient, but all the other patients? And then what will be the socioeconomic impact on the individual, on the family, on the community if they receive this care? If you can answer those questions, which you can do even through a grant, then you're going to have the evidence and you're going to leverage that evidence to ensure that there is more investment, and then you can use even from the lesson that you learn, because you still have to implement in real life. When we make plans are on paper. Reality is in the community. So what we plan on paper and what actually happens in reality can be two different things. So there will also be lessons that you are going to learn, and then from that, then you can then move to nationwide scaling up of the implementation or revising the plan or the policy later on. And so that's the only thing that I can give in terms of advice, that you must ensure you have aligned, you are in the season so that everything is aligned and can work properly. Then go with the initial implementation. People sometimes call it pilot, but I was told by the planning and policy teams that don't call it pilot. Pilot is like something you don't even know. So we call it initial implementation in public health. So do the initial implementation. You can pick on a district. One district with a district hospital and its satellite health facilities. Do it there in a small way. Get what I've said, impact, evidence, lessons, and then bring this back to the ministry, bring this back to the other stakeholders and the partners, then can help with you. Then with the lessons you've learned, then you can start the nationwide.
Thing to say, just raise your hand. And the thing to say, just raise your hand, and the microphone will be brought to you.
Any text?
Dr. Kobsinje has her hand up.
Thank you very much for the opportunity. Thank you very much, PS, for making the time, and for the rest of the panelists. So my question, unfortunately, I have to get back to the 10%, has to do with how we can find the 10%. And from PS's response, it sounds to me like we're still looking around for we're going to knock on doors of banks. And that's all very well, but I'm wondering whether in the current environment, we've all seen what's happened when a major funder pulls their funds, and we're all scrambling to see where we can find money. I'm wondering if within the ministry and within government more broadly, we've started looking more internally at our budgets and looking at the resources that can be found within country, instead of looking outwards to foreign funders maybe. And here I know that the health budget is usually hopefully inadequate, so I'm not thinking you're going to take money from pediatric services or health center force to bring it to surgery, but I'm wondering whether within broader government there are other areas that we could be looking at where those monies can be found, so that we can actually increase the funding within the health envelope so that we can bring funds to this area. A related question has to do with if we are able to relate areas so that, as we said, it's a whole ecosystem. So there are opportunities maybe in climate change. This morning we all experienced huge climate change impacts. Whether we can have funding that comes from those areas that are not traditionally health, but do have huge impacts on health, and how we can make those linkages within government so that we're not looking to foreigners to fund our NSOPs. Thank you very much.
Okay, can we have maybe one more? There's a hand right here.
Thank you. My name is Hans Lokale. I work in Moroto Regional Referral as a general surgeon. Now, if you look at, I'm trying to see this plan. This plan will require a lot of funding to realize it. And there have been discussions on the National Health Insurance Scheme. My question is to Madam PS. How far have we gone in realizing that dream? If you see, most people are thinking of external funding. I'm sure Ugandans can afford 10,000 a year. So if we realize the National Health Insurance Scheme, this big plan will be a reality. And then maybe, I saw in the dailies that if you work in government now, you can't own a private facility. Isn't it contradicting with some of our dreams? Thank you.
You're touching a raw nerve. Okay, I think the PS can take those two.
Let me begin with Olive's question. There's no doubt we don't have sufficient resources to meet all our demands in the sector. When you look at the funding, it is still even below the minimum of 15%. But I am convinced, and I've been telling people, sincerely speaking, yes, it shocked us when our friends, our traditional funders, just pulled away. But it was also a good thing for us to wake up and see that you cannot all the time depend on foreign support forever. It was a wake-up call. And what did we do? We are working now to see how we transition services in a way that we are able to take up these responsibilities that were being handled by the partners. And we have already had a meeting with the Minister of Finance to take up more of our human resource that we're working with partners to absorb. And that means that we are going to increase the wage bill significantly, because the partners were supporting 1,782 workers. And we have already presented that to finance to take up that extra responsibility of absorbing them in service. But we are going to absorb strategically the ones that were, not everyone, but the ones that we feel are critical, like critical staff. Now, coming back to the government financing of the association, I want to believe that part of the work of the association, and I believe everyone here believes so, is that whatever you are doing on behalf of the sector. You are doing everything you do every day is the output of the sector. And therefore, we cannot just look at you like as a separate entity or as a by the way. We need to look at it as part of integral, you are integral part of what the sector is, delivering daily. What has been lacking is that articulation, bringing that plan. how can we now integrate it so that of the priorities that we have, if we are talking about HIV, provision of ART, meeting the cost of the vaccinations. Now, you know now we have 14, including malaria. Meeting the cost of buying those vaccines and all these other priorities. So apart from the vaccines, the ART, the cancer drugs, also surgical services. So surgical services. So yes, I'm not talking about, we are not in vacuum. We are giving services. We are giving surgical services in the country. But what more over and above what you are getting, what you are doing, what more, what priority? If you have your listed things as priorities, what can we pick and incorporate into our plan? This year, next year, what more can we incorporate? That's why I was saying that what are your objectives and what can we phase? And we put as immediate, midterm, and long-term. So we will not avoid this. And for me, it just gives us opportunity to look inside, to look into our systems, so that we bring efficiency. Efficiency. Because the money will not increase so much, even when we have oil. Because I'm told next year we'll start, you know? Yeah. So I want to believe that. But even when we do that, the gap in health financing will not be completely closed. But what are the priorities? What are the priorities on the list? So the surgeons will say, this is our priority. Every regional referral hospital must be able to do minimal access surgery. Every general hospital, these are the minimum services must be there. So then we start. The other day I was meeting some ENT. I think so. Do we have some ENT people here? Yes. So I was meeting one of your staff, and I was like, what are your priorities? Because ENT now, it is mainly in Mulago. Outside Mulago, there is no equipment. So what is your need? What should we do? What is the budget requirement for us to equip every regional referral hospital so that we have the ENT services? Ophthalmologist. We are going to set up a hospital here in Entebbe, ophthalmology and ENT hospital. Specialized. But I was asking, if I said, and I was telling the minister yesterday, that I am, when I think about it, my heart starts shaking. Where will I get the ophthalmologist to work in this? Because we have very, very few. So an entire hospital for ophthalmology, for government. What are we going to do? Therefore, one of the objectives is we must be intentional and train. And yesterday I was meeting PS education, and I quarreled actually. I expressed my disappointment because they put an advert I saw in the paper. It was the advert I saw. Then I was seated with her good enough. I'm like, really? Of the things I wrote to you, of the specialists really we need to train, now you are training tourism to something? And those are the ones you are giving, scholarships? So, but it has to be, well articulated. Now it is now you, the specialist, that you will come and say, looking at the services in the country, looking at the gap that we have, in the next training, we must focus. And I told PS yesterday that I'm going to write. Can I have the submission if I leave, or tomorrow? The surgical specialists gaps that we must focus on and train and push education so that when they are giving scholarships, those are the ones we must prioritize. So we need to, the needs are there, Olive. The needs will be always there. But I think we need to bite, one by one as we go along. Systematically, committedly, with a very clear vision and objective and the target one where we want to go. That's why I was saying we must have very clear objective. We set our targets, and you come to us, and we discuss. Our doors are open. Have we closed the doors? No, we've not closed the doors. Our doors are always open. It's just that sometimes really you find us like in a market. Instead of we have Ebola, we have this, we are running around. So, but we are there. We'll sort. We will be able to handle. National health insurance. We did all our submissions. I don't know why Cabinet up to now they have not discussed that paper. It's the only sure way of alternative health financing that will bridge that gap. It's the only way, because all other countries that have national health insurance, that's how they have managed. And you'll be surprised that when we pull that resource, that the change, the drastic change in quality of service will be palpable, because we'll be able to pull more resources, we'll be able to do more. We did all our part. Everybody's waiting for the national health insurance, including the permanent secretary of Ministry of Health, who is eagerly waiting with you.
Should we make some noise?
Oh my God. I don't know. I can't tell you how much, but we have. We have, and we hope that it is going to come through. It's my hope. The other one of the clinics, I don't know, I saw actually I was away, and someone sent me a screenshot of, I think I saw it on Uganda Medical Association forum. That's when I saw it there. I don't know where it came from. So I had not even read that because I was away. I was not even in the country, but I saw that. So I don't know. I think if you have more information, please let me know. Thank you so much. Thank you.
Thank you very much, Madam PS. Our time is, we're about to reach where we started. We'd like to wrap up, and we want to thank you for coming and addressing some of these issues. I had one, let me just ask about the issue of human resource. Because lots of training is going on. There are some places which have gaps, but there are other places which are doing fairly well. Surgical services, one of the Achilles' heels is the anesthesia. And I think recruitment is not quite meeting our output of infrastructure of units, of theaters, of surgeons. What comments do you have to make about the ban on recruitment, or how are we planning for recruitment on human resources, especially in the area of anesthesia?
No, I think at the moment there is no ban on recruitment. It depends on the wage availability at each level. We have been asking the heads of institutions, the hospitals, to prioritize critical staff. And anesthesiologists, intensivists, acute care nurse, I do believe they are very, very, very critically needed. And we've been encouraging each hospital to prioritize within the budget they have to make sure that they recruit those. It's just that also I have noted that some anesthesiologists, do we have them here in the room as well? Are they with you today?
Right here with us.
Because some anesthesiologists don't want to go up country. They don't want to go up country. When we post them up country, they stay here. They stay in Kampala, others. There's one anesthesiologist, I'm not going to say the name. I'm so disappointed in him. We posted him in Entebbe and he never worked. He never showed up for a whole year. He would go there, work for only 1 hour and just disappear. And then he gets a salary. So we just had to say thank you very much. We don't need your service because you're earning a salary and you are not working really. So it's also, I think it calls for all of us to work on this issue. The individual hospitals, the Ministry of Health, as we are planning based on the resources that we are provided, but also individual workers. We need to change. We need to change. Some of our staff are not doing the right things. They are not. They are cheating government. They earn a salary and they don't work as it should be, as per the standing orders. So even when you are talking about the gaps that we have, sometimes actually are created pseudo gaps because people don't work the right time when they are supposed to be there. Yeah. So yeah, let's talk about this also as well. I hope those ones also you can talk about them. Oh, it's those ones we don't talk about here. Can we also talk about those ones? Is it possible? Yeah, I think let's talk about that as well. Thank you.
Thank you so much. Because Arona has been touched, I think we need to conclude this immediately. We are very grateful for the engagement and the expertise and experience that has been shared by our panelists. And we are sorry that we haven't been able to take, I think I saw a few more hands in the audience, but because of time, we will take one last question for all the panelists. If you had to give us one key priority, action, to help us move Uganda's NSOP forward in the next 12 months, what would it be? We'll start on the extreme end from Professor Makasa.
Thank you so much. I think a key priority action for the Uganda Surgical Society, first of all, comes from the message coming from the PS. The government is ready and willing and waiting for you to help and support them with a policy document that can be integrated into the 4th National Development Plan through the health sector strategic plan. So if you have anything you can do, is to do that. And like I said, for us in SADC and in Zambia, we have done just that. I'm just coming out of Lusaka, and I was leading the revision of the surgical plan. It was not financed by Ministry of Health. We mobilized the resources ourselves and put the whole team together, and we are going to hand over the document to government after it's validated, so that then government can do the right thing, like she clearly said. So if there is anything you can do, is to support the government to do exactly what they've done. The door is open. It's you to help them shape that policy, and then we can see how far we can go.
Thank you. Professor Guel?
I would urge you to document each and every step of the process so that if there is any change in the individuals who are leading the process, they don't start from scratch. If there is any change in the speed, not direction should remain the same. If there's any change in speed, then you have all the information from the beginning very clearly documented. We often don't document enough, and we start repeating what others have done in previous times. Document each and every stage clearly.
All right, thank you for that. Professor Galkande?
Responding to the PS's offer is to ask for a date in the first week of May to do the presentation at the Ministry of Health headquarters of our plan, which will have very clear objectives and targets and asks. So in the first week of May, yeah, that would be my prayer or wish.
Okay, on my side, two things. You will have it. Number two, we'll be able to work on your proposal. as soon as possible to be sure that in the next final, because this coming financial year in July, that one is already done, but in the other financial year, we can catch that the period of financing and incorporate some of your requests. But I also want to say a disclaimer that we will not be able to do everything. Yeah, thank you very much.
Another round of applause to our panelists. Thank you very much, Professor Makasa and Professor Ahmed, Professor Garukande, and PS for sharing from your rich experience. I think the ball is in our court, and it depends on how we play this ball for us to be able to achieve, or at least roll this ball forward to achieve some progress in the area of surgery, obstetrics, and anesthesia. And I think if we stick those three entities together, we will achieve a lot in the area of the knife, delivering a knife and delivering surgical services. Another round of applause to yourselves. You've been a good audience. I want to thank Dr. Mary for being a good modulator. Another round of applause. And maybe another round of applause to myself. Thank you very much. I'd like to request the panelists to resume their seats in the audience and ask Dr. Kakungu to take over. Thank you very much. We're supposed to have a group picture from here, right? Okay.
Asante sana.
As we gather ourselves and prepare for the opening ceremony, we once again welcome you all in your various portfolios and stations, and thank you all for braving the lakes and the rivers to make it here. We are so privileged to have various people who have come from far and wide. Some of them have already been introduced, but allow me to give a brief introduction and another welcome, a special welcome to our special guests, starting with Dr. Ahmed Ogwell, who has been here. He's already been introduced. Can we please give a round of applause? We thank you so much and for going across the borders and coming from Kenya, but much as you're based in Kenya, you've also got a wealth of experience with the UN in Congo Brazzaville, based on your CV, and with Africa CDC, and as the CEO of African CDC. So we appreciate you, and we welcome you to Uganda, and we welcome you to the Association of Surgeons of Uganda. The next person I also want to welcome in a special way is Professor Makasa Emmanuel, aka Professor Mukasa. He's been baptized today with permission from the past president, Frank Asimwe, who went to the Kabaka, who is the traditional ruler of the Baganda, and who was baptized you Mukasa. But Professor Makasa, we are very, very privileged to have you with us, and we thank you for coming and joining us all the way from Zambia, Lusaka. I'm told that, thank you. Zambians and Ugandans are just brothers and sisters from a different mother. If you go to Lusaka and they start speaking, we can understand what they are saying. So be careful what you say about Professor Makasa. He'll understand what you're saying. Be careful. At this juncture, I don't want to take too much time. I'm going to welcome the president of the Association of Surgeons of Uganda. This is Professor Moses Galukande, to give us his opening remarks and also to welcome our guest of honor. And thereafter, we will have a tour of the exhibition. So, Professor Galukande, you're welcome to invite us officially to this conference. Thank you.
Ladies and gentlemen, once again, thank you very much for making the time, all protocol observed. You're very welcome to this National Surgical Exhibition and Annual Scientific Conference for us. So I'm trying to figure out what number is this? Must be close to 20 maybe. I don't know if Dr. Sakawira remembers. I think we need to figure out what number this is so that next time we'll put the number. But you're very welcome to this conference and function. It's very important to us for many reasons. We need to advance the cause of surgical practice in the country. And this platform becomes very important for us to showcase not only what we do, but what we hope to be, but also to reflect on our past. It's so important to us because it's also a platform to inspire the next generation so that they see what can be done, they see the interaction so that the association grows. Not just for the sake of growth, but at the end of the day, we are called to serve the population. And actually not only in this country, but in the region, because we indeed collaborate and also link up with surgeons from other countries. So this is important to us. It's a core activity we run every year. And so I wanted to make that point. But the second thing is it looks like in life, the important things we do, we can't do alone. It's also true that the things we succeed in, it's unlikely that we've managed alone. So we appreciate all our sponsors, our supporters, our collaborators, and the Ministry of Health. We appreciate your support. We appreciate your presence. We know very well you're pulled in many directions, but you always come, and we can't take that for granted. We appreciate that support very much, and thank you for the challenge you've given us. We're going to present that document to you at the soonest. Once again, thank you very much. We appreciate your time, your presence, and your input. And I'll take this opportunity to welcome our guest of honor, the PS, to say something to us before we go for the walk around and lunch. I don't know what comes first. I don't know whether lunch comes first or the walk around. Thank you very much.
Between them and lunch. I know that it is time for lunch, so I don't want really to stand between you and lunch. I made a few remarks earlier in my own when I was on the panel, so I'll make it very short. Allow me to recognize the protocol, entire executive of ASAO, led by the chair, and I'm happy to see our senior, Professor Maswa. Thank you so much, always being there. Just wherever we are, you are there. We just pray that God continue to give you strength, and we continue get, we reap from your experience. And want to really recognize all our senior friends amongst us, our guests, foreign guests from outside the country. I want also to acknowledge Professor Muhammad Ahmad from African Union. You kept on saying in Kenya, but for me I see him as African Union. So yeah, so I want to say African Union is represented here. Allow me to bring greetings from Ministry of Health. I think my minister may come to close. She was not, we were actually in a retreat, but I escaped from the retreat to come this way. I just allow me to say just three things briefly. The first one is to appreciate the work that the Association of the Surgeons, Anesthesiologists, Obstetrician, I know they are not here, but I know you do more or less the same work. We want to appreciate you so much for the work that you are doing, the burden you carry, and the output you are able to deliver in our hospitals. We want to specifically thank you for coming together annually to showcase what you have been able to do, the skill set that you have, and also to bring all the surgeons together, the old and the young together, so that you inspire, but also you keep the young ones closer to you, the old ones, so that we have continuity. We want to thank you so much for creating this platform that brings all of us together every year to discuss the science, to share the experience, but also to showcase to whoever minds to come to see what you are doing. Last time it was really an amazing work that you did in Kololo. I remember many people came and they kept on tweeting. I kept on seeing tweets, and they were talking about the skills they didn't know that you have in the country. And so this is the way to go. If we don't blow our trumpet, nobody will blow that trumpet for us. So the first thing I just want to request all of you is that I know that doctors, you're not supposed to advertise yourselves. You are not, that is not really the skill that we have. But we need to build confidence to the public that the skill set that we have in this country, by and large, it can handle the really, really big percentage of surgical work that is needed in the country. We have the skill set, we have what it takes. Sometimes what is missing in the link is how we take this information outside. But also I know that we have the skill, but also we don't have adequate equipment to enable us do whatever we want to do. And for me, the immediate, in your plan, Dr. Galukande, in your plan, the immediate is what the equipment that you need to deliver to reduce the hemorrhage of resources, letting people go outside. What are those? Once they are well articulated, then we'll go. My minister, I want to tell you, we'll prepare a cabinet memo and we'll go to cabinet and make a special presentation for that. So let's begin, and we cut out this elephant in pieces. So we take that. So let's articulate, what do we need? The skills among the human resources, I think really we have significant skills in the country. But I think we are not optimizing that skill because of the gaps in the infrastructure. And so if we can first deal with some infrastructure, we may not do all, but at least we start that journey. So that is number one. Number two, we need to see the strength in you through unity. We want to feel the strength that, you cannot. This association, no. If they say no, you just cannot. You can't go beyond this one, no. Forget about those things of, okay, let me not say, because I know that they will quote me. You misquote me. I'm always misquoted. I don't know why. So let me not go there. Because I was going to tell you, should I? Okay, let me not. The association, the professional associations, for us as Ministry of Health, we take it more serious than just Uganda Medical Association. Because professional, you are who you are because of your profession, your skill, what you can deliver, what you are able to deliver to us. So for me, this professional association, it is worth listening to, working with, planning with, and executing with, because it is just driving us into the direction that is pushing us to make things happen. Than just association. Association, I can just be in any association, I can be in Rotary, I can be what, and yeah, but when we talk about really professional associations, we want to see unity, strength, policy formulation coming out of your, we want to see the brains at work. My goodness, I see some of those forums, and I'm like, hey, our doctors, you mean this is how we have reduced ourselves, really? Is this the discussion? Is this the caliber of who would be discussing science, policy shift? What do we need to do? How do we move to? How do we build strength in professionalism? How do we bring strength in skill sets? How do we bring strength in ethical behavior of our associations, of our teams? So for me, this is something that I really want to see now, the strength in unity, the unity. Okay, I'd said I was going to say a few words. Okay, lastly, I also really request that what you have started, let it not lose momentum. Sometimes, depending on the leaders of these associations, when you get leadership that is not really able to mobilize, able to knock on doors of this, mobilize this, somehow the weakness sets in. We want to see that momentum that you have built for the last 3 years and the output you are able to deliver and the momentum you are building, you are a force that no one will ignore you because of what you are able to do in the country, the impact you are creating. I want to tell you those surgeries you go to do, 2,000, where has that ever happened? That in 1 week you have operated 2,000? Where? So even those that don't want to listen, or those who don't want to know, they will be forced to know and to listen and to act. So let's maintain the momentum. Let's not just get up and then another year we are down, then we are limping. We want to see this momentum built up, and we are available to support. Ministry of Health is available to support. And we are sorry we were not able to send our support earlier, but I came with some contribution because really I felt so embarrassed. We were supposed to have sent it, but I was away. Moses, and Frank, when you wanted to come and for us discuss the funding, it was not possible. But I came with a small contribution. I will hand it over to you. So thank you very much, and we wish you great deliberations. And
hear me? Yes. First of all, we'd like to thank our Cabinet Secretary. I will say our because she's really stood with us through thick and thin in various platforms, especially as the Association of Surgeons of Uganda. We don't take it for granted. Thank you very much for the support you've given us over the years. This is not just something that started recently. It's been a long journey, and she's been there throughout. Thank you very much. And at this juncture, I would welcome Professor Galukande to give a small token of appreciation and a memento about your time with us as we prepare for the next phase of the conference.
Small, but from the heart.
Yes. Before we leave the podium, I would like to, first of all, before we go down for the exhibition, we need to do what we call an accountability photo. So we need all of us to come to the front so that we can take a group photo. For all of you who had to get letters and communication to your employers that you are attending this conference, please make sure you are seen in this photo. And so please, let's do this quickly. If we can all come to the front and take this photo before we go down to look at the exhibition and lunch. The first people will get the opportunity to stand next to the PS. As we position ourselves, I like to recognize the presence of our seniors, Professor Omaswa, Dr. Birawa Made, Dr. Alex Cotino. You're all very welcome. Dr. Sekavira.
ASO is the Association of Surgeons of Uganda.
The call to the Association of Surgeons of Uganda is to take interest in this legacy of Professor Chalwazi, especially the area of collaboration. I want us to develop a very strong department of surgical oncology at the Uganda Cancer Institute.
Then they thought they should have been guiding policies of consent, and they had challenges communicating risk. And the documentation, they felt that whatever they communicated should actually be documented. So it's clear that I have been told this and this about a particular procedure.
In context of informed consent, with also refresher trainings to address the different dilemmas that are facing the process of informed consent.
Is there a way we can put systems and checkpoints in place to reduce surgical errors? Is there amnesty for those who have these incidences? And what about patient advocacy?
Continuous use of surgical safety checklists as a rule, not an exception. Operating rooms would use customized dashboards to monitor their safety and efficiency matrices.
Clear communication throughout the surgical process. You create an environment where everyone feels empowered to speak up.
Let us empower the nurses. There we shall have things done in the right way by the right team, and we shall have better surgical outcomes.
If you want to be a great department of surgery or anesthesia or urology, you're going to be a great department because you take great care of patients in your department. That great care will drive great papers, will drive grants based on the production of patients that you take care of.
So are you passionate about what you do in the operating room, or are you passionate about teaching?
Strive to remain relevant even after active surgical practice.
Improve the quality of care that we are providing for these patients and to build capacity.
Ladies and gentlemen, let's make our way to the exhibition tents, please. As we proceed to lunch, let's make our way to the exhibition tent. We're going to accompany the guest of honor. Let's make our way to the exhibition tent.
So is the Association of Surgeons of Uganda. So is the Association of Surgeons of Uganda.
In the hills of western Uganda, we witnessed something extraordinary. The courage of patients, the dedication of health workers, and the unwavering spirit of humanity. In the heart of the western Uganda region, where access to surgical care is limited, hope emerged for countless individuals in need. Over the course of several days, a dedicated team of healthcare providers from the Association of Surgeons of Uganda of all specialities, together with the Ministry of Health and their partners, including nurses, radiologists, pathologists, laboratory and diagnostics, anesthesia providers, and public health, came together for a free Ankole sub-region surgical camp designed to bring relief to those who need it most.
Kabandia ukarumu interesse konkar kampara yangambrati ebraber nabiri harhaba sagoni benda kuiza ayirware bakweta ko intershebe mbeno rebe kungwe berebi wajirota wazai derba kurebe bakuchebere barebe yana bafa kusemezani gukora
erisur biendia amweru bierita kurebe
nabendiaho bangambira nkukeyayu hariyo kampu kandi nesemereza busha niza nahikaha batwakira je nitsimo buhereza ngona over tuherize.
All so far is good, the enthusiasm is good, the turn-up, as you may have seen outside.
That the challenges bring us together, to work together, to strengthen each other, because this is a journey not for one person, it's a journey for every one of us.
This was more than just a medical outreach. This surgical camp was a lifeline. From dawn to dusk, surgeons performed life-changing procedures, offering their expertise to individuals suffering from conditions that had long gone untreated. Patients received critical medical treatment that restored their health and hope for the future. For many, this was a once-in-a-lifetime opportunity. Many gathered to receive the medical care they desperately needed. But thanks to the generosity and dedication of the surgical team from the Association of Surgeons of Uganda, thousands of people have been touched. This surgical camp was not just about healing bodies. It was about mending hearts and building stronger, healthier communities. Thank you to everyone who made this possible. From the partners and sponsors, to the brave patients who trusted us with their care, and the healthcare providers from the Association of Surgeons of Uganda.
We're looking forward to next year. We promise to go to the West Nile sub-region in northern Uganda, and we shall do the same. We thank all our sponsors. We anticipate that you'll come back on board to also go to the people in the West Nile sub-region and serve them as well as we've done in the Ankole sub-region. So is the Association of Surgeons of Uganda.
We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
If we had our surgeons populate the peripheral hospitals, especially the senior ones, that would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do. Because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
And timely surgical care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives.
Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many patients we treat with these established methods, we do ourselves and our patients a disservice. So let's not settle for the technician role, grand as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons.
The practice should change, but most important also the policies. Does our curriculum in surgery actually ask the resident to understand statistics? We might still be researching on things that are for the 20th century.
But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might.
All the children who are under maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to all regional referral hospitals, probably that's when we can try to address some of these conditions.
That I don't think we have a surgical problem. We have a leadership problem. So we need to think about the stories and how we tell the stories to our society.
We need trauma surgeons. Please do some training in trauma. Trauma is taking its toll on Ugandans.
Get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes, you will have a mentor for your clinical work, sometimes for research.
So is the Association of Surgeons of Uganda.
Something extraordinary. The courage of patients, the dedication of health workers, and the unwavering spirit of humanity. In the heart of the Western Uganda region, where access to surgical care is limited, hope emerged for countless individuals in need. Over the course of several days, a dedicated team of healthcare providers from the Association of Surgeons of Uganda of all specialities, together with the Ministry of Health and their partners, including nurses, radiologists, pathologists, laboratory and diagnostics, anesthesia providers, and public health, came together for a free Ankole sub-region surgical camp designed to bring relief to those who need it most.
Kabandia hukarumu interesse konkar kampara yang berarti Ebra bernabiri harha basago ni benda kuiza ayirware bakweta ko ni tertiary mbeno rebe kungwebere bi wajirota wazai derba kurebe bakuchebere barebe yana basa kusemeza ni gukora
Erisur byendi India amweru byerita kureba
kina bendi aho bangambira nkukeyayu hariyo kampu kandi nesemereza busha niza nahikaha batwakira je nitsimo buhereza ngona over tuherize.
All so far is good, the enthusiasm is good, the turn-up, as you may have seen outside.
That the challenges bring us together, to work together, to strengthen each other, because this is a journey not for one person, it's a journey for every one of us.
This was more than just a medical outreach. This surgical camp was a lifeline. From dawn to dusk, surgeons performed life-changing procedures, offering their expertise to individuals suffering from conditions that had long gone untreated. Patients received critical medical treatment that restored their health and hope for the future. For many, this was a once-in-a-lifetime opportunity. Many gathered to receive the medical care they desperately needed. But thanks to the generosity and dedication of the surgical team from the Association of Surgeons of Uganda, thousands of people have been touched. This surgical camp was not just about healing bodies. It was about mending hearts and building stronger, healthier communities. Thank you to everyone who made this possible. From the partners and sponsors, to the brave patients who trusted us with their care, and the healthcare providers from the Association of Surgeons of Uganda.
We're looking forward to next year. We promise to go to the West Nile sub-region in northern Uganda, and we shall do the same. We thank all our sponsors. We anticipate that you'll come back on board to also go to the people in the West Nile sub-region and serve them as well as we've done in the Ankole sub-region.
The call to the Association of Surgeons of Uganda is to take interest in this legacy of Professor Chalwazi, especially the area of collaboration. I want us to develop a very strong department of surgical oncology at the Uganda Cancer Institute.
Then they thought they should have been guiding policies of consent, and they had challenges communicating risk. And the documentation, they felt that whatever they communicated should actually be documented. So it's clear that I have been told this and this about a particular procedure.
In context of informed consent, with also refresher trainings to address the different dilemmas that are facing the process of informed consent.
Is there a way we can put systems and checkpoints in place to reduce surgical errors? Is there amnesty for those who have these incidences? And what about patient advocacy?
Continuous use of surgical safety checklist as a rule, not an exception. Operating rooms would use customized dashboards to monitor their safety and efficiency matrices.
Clear communication throughout the surgical process. You create an environment where everyone feels empowered to speak up.
Let us empower the nurses. There we shall have things done in the right way by the right team, and we shall have better surgical outcomes.
If you want to be a great department of surgery or anesthesia or urology, you're going to be a great department because you take great care of patients in your department. That great care will drive great papers, will drive grants based on the production of patients that you take care of.
So are you passionate about what you do in the operating room, or are you passionate about teaching?
Strive to remain relevant even after active surgical practice.
Improve the quality of care that we are providing for these patients and to build capacity.
Today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
If we had our surgeons populate the peripheral hospitals, especially the senior ones, that would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated, and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do, because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Together with the scientific committee, we are pleased to present this year's conference theme, Advancing Access to Safe, Affordable and Timely Surgical Care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives.
Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many people with these established methods, we do ourselves and our patients a disservice. So let's not settle for the technician as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons.
The practice should change, but most important also the policies. Does our curriculum in surgery actually ask the resident to understand statistics? We might still be researching on things that are for the 20th century.
But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might.
All the children who are under maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to regional referral hospitals, probably that's when we can try to address some of these conditions.
That I don't think we have a surgical problem. We have a leadership problem. So we need to think about the stories and how we tell the stories to our society.
need trauma surgeons. Please do some training in trauma. Trauma is taking its toll on Ugandans.
Get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes, you will have a mentor for your clinical work, sometimes for research.
So is the Association of Surgeons of Uganda.
In the hills of western Uganda, we witnessed something extraordinary. The courage of patients, the dedication of health workers, and the unwavering spirit of humanity. In the heart of the western Uganda region, where access to surgical care is limited, hope emerged for countless individuals in need. Over the course of several days, a dedicated team of healthcare providers from the Association of Surgeons of Uganda of all specialities, together with the Ministry of Health and their partners, including nurses, radiologists, pathologists, laboratory and diagnostics, anesthesia providers, and public health, came together for a free Ankole sub-region surgical camp designed to bring relief to those who need it most.
kabandi yaho karamu interesi konkar kampara yangambarati ibrahim nabiri harho abashaho nigenda kwiza ayirwara rwo kweta ko intershebe ngweno rebe ngwebere wagirota wazayi dere bakurebe bakucebere barebe yano basa kushemeza niga gukora
erisho byendi India amweru byerita kureba
bendi yaho bangambira nkukeyayu hariyo kampu kandi nesemereza busha niza nahikaha batwakira je nitsimo buhereza ngona over tuherize.
All so far is good, the enthusiasm is good, the turn-up, as you may have seen outside.
That the challenges bring us together, to work together, to strengthen each other, because this is a journey not for one person, it's a journey for every one of us.
This was more than just a medical outreach. This surgical camp was a lifeline. From dawn to dusk, surgeons performed life-changing procedures, offering their expertise to individuals suffering from conditions that had long gone untreated. Patients received critical medical treatment that restored their health and hope for the future. For many, this was a once-in-a-lifetime opportunity. Many gathered to receive the medical care they desperately needed. But thanks to the generosity and dedication of the surgical team from the Association of Surgeons of Uganda, thousands of people have been touched. This surgical camp was not just about healing bodies. It was about mending hearts and building stronger, healthier communities. Thank you to everyone who made this possible. From the partners and sponsors, to the brave patients who trusted us with their care, and the healthcare providers from the Association of Surgeons of Uganda.
We're looking forward to next year. We promise to go to the West Nile sub-region in northern Uganda, and we shall do the same. We thank all our sponsors. We anticipate that we'll come back on board to also go to the people in the West Nile sub-region and serve them as well as we've done in the Ankole sub-region.
The call to the Association of Surgeons of Uganda is to take interest in this legacy of Professor Chalwazi, especially the area of collaboration. I want us to develop a very strong department of surgical oncology at the Uganda Cancer Institute.
Then they thought they should have been guiding policies of consent, and they had challenges communicating risk. And the documentation, they felt that whatever they communicated should actually be documented. So it's clear that I have been told this and this about a particular procedure.
In context of informed consent, with also refresher trainings to address the different dilemmas that are facing the process of informed consent.
Is there a way we can put systems and checkpoints in place to reduce surgical errors? Is there amnesty for those who have these incidences? And what about patient advocacy?
Continuous use of surgical safety checklist as a rule, not an exception. Operating rooms would use customized dashboards to monitor their safety and efficiency matrices.
clear communication throughout the surgical process. You create an environment where everyone feels empowered to speak up.
Let us empower the nurses. There we shall have things done in the right way by the right team, and we shall have better surgical outcomes.
If you want to be a great department of surgery or anesthesia or urology, you're going to be a great department because you take great care of patients in your department. That great care will drive great papers, will drive grants based on the production of patients that you take care of.
So are you passionate about what you do in the operating room, or are you passionate about teaching?
Strive to remain relevant even after active surgical practice.
Improve the quality of care that we are providing for these patients and to build capacity.
Today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
If we had our surgeons populate the peripheral hospitals, especially the senior ones, that would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated, and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do. Because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availabilities in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Together with the scientific committee, we are pleased to present this year's conference theme, Advancing Access to Safe, Affordable and Timely Surgical Care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives.
Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many patients we treat with these established methods, we do ourselves and our patients a disservice. So let's not settle for the technician role, grand as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons.
The practice should change, but most important also the policies. Does our curriculum in surgery actually ask the resident to understand statistics? We might still be researching on things that are for the 20th century.
But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might.
All the children who are under maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to regional referral hospitals, probably that's when we can try to address some of these conditions.
That I don't think we have a surgical problem. We have a leadership problem. So we need to think about the stories and how we tell the stories to our society.
We need trauma surgeons. Please do some training in trauma. Trauma is taking its toll on Ugandans.
Get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes you'll have a mentor for your clinical work, sometimes for research.
So is the Association of Surgeons of Uganda.
I got joy, 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 joy.
In the hills of western Uganda, we witnessed something extraordinary. The courage of patients, the dedication of health workers, and the unwavering spirit of humanity. In the heart of the western Uganda region, where access to surgical care is limited, hope emerged for countless individuals in need. Over the course of several days, a dedicated team of healthcare providers from the Association of Surgeons of Uganda of all specialities, together with the Ministry of Health and their partners, including nurses, radiologists, pathologists, laboratory and diagnostics, anesthesia providers, and public health, came together for a free Ankole sub-region surgical camp designed to bring relief to those who need it most.
kabandi ya hukaro interesi konkar kampara yangambarati ebra barnabiri harha basago ni benda kuiza ayirware rwo kweta ko intershebe mbeno rebe kungwe berebi wajirota wazai derba kurebe bakuchebere barebe yana baso kusemeza ni gukora
erisuru byendi India amweru byerita kureba
bendi yaho bangambira nkukeyayu hariyo kampu kandi nesemereza busha niza nahikaha batwakira je nitsimo buhereza ngona over tuherize.
All so far is good, the enthusiasm is good, the turn-up, as you may have seen outside.
That the challenges bring us together, to work together, to strengthen each other, because this is a journey not for one person, it's a journey for every one of us.
This was more than just a medical outreach. This surgical camp was a lifeline. From dawn to dusk, surgeons performed life-changing procedures, offering their expertise to individuals suffering from conditions that had long gone untreated. Patients received critical medical treatment that restored their health and hope for the future. For many, this was a once-in-a-lifetime opportunity. Many gathered to receive the medical care they desperately needed. But thanks to the generosity and dedication of the surgical team from the Association of Surgeons of Uganda, thousands of people have been touched. This surgical camp was not just about healing bodies. It was about mending hearts and building stronger, healthier communities. Thank you to everyone who made this possible. From the partners and sponsors, to the brave patients who trusted us with their care, and the healthcare providers from the Association of Surgeons of Uganda.
We're looking forward to next year. We promise to go to the West Nile sub-region in northern Uganda, and we shall do the same. We thank all our sponsors. We anticipate that you'll come back on board to also go to the people in the West Nile sub-region and serve them as well as we've done in the Ankole sub-region.
The call to the Association of Surgeons of Uganda is to take interest in this legacy of Professor Chalwazi, especially the area of collaboration. I want us to develop a very strong department of surgical oncology at the Uganda Cancer Institute.
Then they thought they should have been guiding policies of consent, and they had challenges communicating risk. And the documentation, they felt that whatever they communicated should actually be documented. So it's clear that I have been told this and this about a particular procedure.
In context of informed consent, with also refresher trainings to address the different dilemmas that are facing the process of informed consent.
Is there a way we can put systems and checkpoints in place to reduce surgical errors? Is there amnesty for those who have these incidences? And what about patient advocacy?
Continuous use of surgical safety checklist as a rule, not an exception. Operating rooms would use customized dashboards to monitor their safety and efficiency matrices.
Clear communication throughout the surgical process. You create an environment where everyone feels empowered to speak up.
Let us empower the nurses. There we shall have things done in the right way by the right team, and we shall have better surgical outcomes.
If you want to be a great department of surgery or anesthesia or urology, you're going to be a great department because you take great care of patients in your department. That great care will drive great papers, will drive grants based on the production of patients that you take care of.
So are you passionate about what you do in the opera? Passionate about teaching?
Strive to remain relevant even after active surgical practice.
Improve the quality of care that we are providing for these patients and to build capacity.
For the Association of Surgeons of Uganda, it's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
the small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
If we had our surgeons populate the peripheral hospitals, especially the senior ones, that would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated, and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do, because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Together with the scientific committee, we are pleased to present this year's conference theme, Advancing Access to Safe, Affordable and Timely Surgical Care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives.
Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many patients we treat with these established methods, we do ourselves and our patients a disservice. So let's not settle for the technician role, grand as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons.
The practice should change, but most important also the policies. Does our curriculum in surgery actually ask the resident to understand statistics? We might still be researching on things that are for the 20th century.
But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might.
All the children who are under
maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to all regional referral hospitals, probably that's when we can try to address some of these conditions.
That I don't think we have a surgical problem. We have a leadership problem. So we need to think about the stories and how we tell the stories to our society.
We need trauma surgeons. Please do some training in trauma. Trauma is taking its toll on Ugandans.
Get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes you'll have a mentor for your clinical work, sometimes for research.
So is the Association of Surgeons of Uganda.
In the hills of western Uganda, we witnessed something extraordinary. The courage of patients, the dedication of health workers, and the unwavering spirit of humanity. In the heart of the western Uganda region, where access to surgical care is limited, hope emerged for countless individuals in need. Over the course of several days, a dedicated team of healthcare providers from the Association of Surgeons of Uganda of all specialities, together with the Ministry of Health and their partners, including nurses, radiologists, pathologists, laboratory and diagnostics, anesthesia providers, and public health, came together for a free Ankole sub-region surgical camp designed to bring relief to those who need it most.
Kabandi yang karu mungkin terus pongkar kampara yang gambarati Ibrahim Bernabiri harhaba sahun jenda kuiza ayruar reba kota komin terchere mbeno reba kungwe berebi wajirota wazai dereba kurebe bakuche bere barebi yana baso kuseme zani gukora
Erisur biendi India amweru bierita kureba
nabendi aho bangambira nkukeyayu hariyo kampu kandi nesemereza busha niza nahikaha batwakira je nitsimo buhereza ngona over tuherize.
All so far is good, the enthusiasm is good, the turn-up, as you may have seen outside.
That the challenges bring us together, to work together, to strengthen each other, because this is a journey not for one person, it's a journey for every one of us.
This was more than just a medical outreach. This surgical camp was a lifeline. From dawn to dusk, surgeons performed life-changing procedures, offering their expertise to individuals suffering from conditions that had long gone untreated. Patients received critical medical treatment that restored their health and hope for the future. For many, this was a once-in-a-lifetime opportunity. Many gathered to receive the medical care they desperately needed. But thanks to the generosity and dedication of the surgical team from the Association of Surgeons of Uganda, thousands of people have been touched. This surgical camp was not just about healing bodies. It was about mending hearts and building stronger, healthier communities. Thank you to everyone who made this possible. From the partners and sponsors, to the brave patients who trusted us with their care, and the healthcare providers from the Association of Surgeons of Uganda.
We're looking forward to next year. We promise to go to the West Nile sub-region in northern Uganda, and we shall do the same. We thank all our sponsors. We anticipate that you'll come back on board to also go to the people in the West Nile sub-region and serve them as well as we've done in the Ankole sub-region.
The call to the Association of Surgeons of Uganda is to take interest in this legacy of Professor Chalwazi, especially the area of collaboration. I want us to develop a very strong department of surgical oncology at the Uganda Cancer Institute.
Then they thought they should have been guiding policies of consent, and they had challenges communicating risk. And the documentation, they felt that whatever they communicated should actually be documented. So it's clear that I have been told this and this about a particular procedure.
In context of informed consent, with also refresher trainings to address the different dilemmas that are facing the process of informed consent.
Is there a way we can put systems and checkpoints in place to reduce surgical errors? Is there amnesty for those who have these incidences? And what about patient advocacy?
Continuous use of surgical safety checklist as a rule, not an exception. Operating rooms would use customized dashboards to monitor their safety and efficiency matrices.
Clear communication throughout the surgical process. You create an environment where everyone feels empowered to speak up.
Let us empower the nurses. There we shall have things done in the right way by the right team, and we shall have better surgical outcomes.
If you want to be a great department of surgery or anesthesia or urology, you're going to be a great department because you take great care of patients in your department. That great care will drive great papers, will drive grants based on the production of patients that you take care of.
So are you passionate about what you do in the operating room, or are you passionate about teaching?
Strive to remain relevant even after active surgical practice.
Improve the quality of care that we are providing for these patients and to build capacity.
Today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
If we had our surgeons populate the peripheral hospitals, especially the senior ones, that would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated, and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do, because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Together with the scientific committee, we are pleased to present this year's conference theme, Advancing Access to Safe, Affordable and Timely Surgical Care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives.
Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many patients we treat with these established methods, we do ourselves and our patients a disservice. So let's not settle for the technician role, grand as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons.
The practice should change, but most important also the policies. Does our curriculum in surgery actually ask the resident to understand statistics? We might still be researching on things that are for the 20th century.
But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might.
All the children who are under maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to regional referral hospitals, probably that's when we can try to address some of these conditions.
That I don't think we have a surgical problem. We have a leadership problem. So we need to think about the stories and how we tell the stories to our society.
We need trauma surgeons. Please do some training in trauma. Trauma is taking its toll on Ugandans.
Get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes you'll have a mentor for your clinical work, sometimes for research.
ASO is the Association of Surgeons of Uganda.
In the hills of western Uganda, we witnessed something extraordinary. The courage of patients, the dedication of health workers, and the unwavering spirit of humanity. In the heart of the western Uganda region, where access to surgical care is limited, hope emerged for countless individuals in need. Over the course of several days, a dedicated team of healthcare providers from the Association of Surgeons of Uganda of all specialities, together with the Ministry of Health and their partners, including nurses, radiologists, pathologists, laboratory and diagnostics, anesthesia providers, and public health, came together for a free Ankole sub-region surgical camp designed to bring relief to those who need it most.
Kabandi ya ukaru mutianteres konkaru kampara yang gambarati Ibrahim Nabiri harhaba sahu nizenda kuiza ayirware rwakota ko mintershere mbeno rebu kungwe berebi wajirota wazai deriba kurebe bakuchebere barebi yana basa kusemeza niga gukora
erisoro byendia amweru byerita kureba
nabendiaho bangambira nkukeyayu hariyo kampu kandi nesemereza busha niza nahikaha batwakira je nitsimo buhereza ngona over tuherize.
All so far is good, the enthusiasm is good, the turn-up, as you may have seen outside.
That the challenges bring us together, to work together, to strengthen each other, because this is a journey not for one person, it's a journey for every one of us.
This was more than just a medical outreach. This surgical camp was a lifeline. From dawn to dusk, surgeons performed life-changing procedures, offering their expertise to individuals suffering from conditions that had long gone untreated. Patients received critical medical treatment that restored their health and hope for the future.
Let's please come back into the room so that we can proceed with the next session. We are going into session 2, which is the surgical ecosystem, and it's going to be chaired by Dr. John Sekabira. We are going to twist our program slightly as we wait for all the members to come back into the hall, so that we can have the keynote when everyone is seated. So the slight change is to ensure that we can all benefit from our keynote speaker. So
good afternoon. Good afternoon. I think everybody is having high sugar levels after lunch. I would expect a much louder greetings. Anyway, without further ado, we are already, I think, late, I have to mention. But as Dr. Kakungula has mentioned, we are going to make some changes. So I would want to call upon Dr. Brian Kasaga to make his presentation. Is he around? Is Dr. Brian around? I'd been informed that he's around, that's why we... Maybe we can, Dr. Nasos Jarila, as we wait for Dr. Kasaga, so that we save some time. Yes, you can come up and you can go to the podium. Dr. Nasser Jarila is going to tell us about something about the role of neurosurgeons in shaping road traffic policy to prevent traumatic brain injury. You're welcome, Dr. Nasser.
Thank you. Hello, good afternoon, everyone. Yeah, my name is Nasozi Jarila. I'm an FCS COSEXA resident. And postgraduate year 5. So I'm here to talk about the role neurosurgeons have to play in combating traumatic brain injury through road traffic accidents, how they can influence policy, and why it is very important to us. So, as Uganda, As you can see, that was the report from the 2024 from the traffic police. We registered 1,400 more road crashes in 2024. And of that, they left so many fatalities, which even included deaths. So why TBI and why is it important? So it's been classified as a silent pandemic worldwide, and the majority of the cases we usually see, they are from road traffic accidents. Why is it important to the neurosurgeons? It is important to us because we witness the effects of TBI to society and to individuals firsthand. And so we have a very big role. I know, like generally doctors and physicians, they all have a big role in influencing policy. But if you look at it, I think maybe in the last 10 years, that's when doctors have actually come out to be involved in policy, and we still have a very long way to go. So when you look at the epidemiology of road traffic accidents, globally we have like around 1.3 million deaths annually. And of course 50 will have like mild head injury. Then when you look at it in the low middle income countries, sub-Saharan, we usually have 90% of the TBIs will come from the road traffic accidents. And we do have this because we have poor road safety laws and also discipline on the roads. And it's usually affecting the productive years, that is the 15 to 45 years. And of course, males usually have a very high risk for the TBIs. So when you come back to Uganda, a research was done that was in 2019 at Mulago, Causes and Outcomes of Traumatic Brain Injuries in Uganda. And it identified the non-intentional TBI causes, came out at 60.7% out of 3,569 patients, while the intention were 30.1. However, when you look at it, the non-intentional ones, road traffic accidents, they accounted for more than 80% of them. And it was mostly the border riders and the pedestrians. And most of the time, of course, we talk about the borders causing a lot of accidents. But if they have been run over by a car, it's not like it's only involving them. So we don't have the statistics on exactly. Yes, we know it's mostly border riders who come actually to our public hospitals because they can't afford the private. Then we also miss out on that. So what's the cost of TBI? The cost of TBI can be in terms of finances and also in terms of productivity, because most of the time, if you've had severe TBI, there is no way you are going to be productive after that, even if it has been moderate or mild, and most probably you've gotten like sequela from it, like epilepsy. Someone who was previously functional is not going to be functional. So in a study which was done in America, TBI alone costs a patient between $1,000 to $18,000. And most of our patients here, they cannot have that kind of money. So when it comes to healthcare costs, where you look at the ICU admissions, prolonged hospitalization, neurosurgical interventions, long-term rehabilitation, it is really very costly. And the economic burden, which shows up in terms of productivity, and also the financial strains on families and healthcare systems. Because also, when you look at it, most of the population here does not have health insurance. Then in the US alone, TBI-related injuries will cost in excess of $76 billion annually. So I'm going to just talk about a case study of a country which has managed to drop its RTAs by 50%, and this is Sweden. So they came up with the Vision Zero, and when they introduced it, that was in 1997, more than 20 years ago. And as per now, when you look at their statistics, the road traffic accidents have fallen by 50%. They realized, yeah, we cannot stop these road traffic accidents from happening, but we should make sure we do not lose people or have fatal cases from them. So what exactly they did, they are very strict. And I think we also realized that Sweden is one of the most disciplined countries in the world during COVID. So they, of course, do the strategies, strict speed limits, seat belts, safer road infrastructure, zero tolerance to drunk driving, and also they included all the other stakeholders, such as the manufacturers of motor vehicles, transport systems, every stakeholder plus the Ministry of Health, their Ministry of Works and Roads, in order to achieve and maintain this. So that is one, because they have the lowest road traffic mortalities globally. So what would be the recommendations or the policy changes which neurosurgeons can recommend? Of course, helmet and seat belts, speed limit regulations, being very strict on drunk driving. And someone will tell me, of course, these are things we have talked about, I think, since childhood, because even when we are in primary, we are talked about obey traffic lights and everything. So nothing has changed. And why is that? Because of lack of discipline and lack of accountability. That's the biggest thing. And then the other thing, when we are forming these policies, we need to engage everyone down from the community. If you come up and you tell them, okay, we are having this problem, we don't think people should be drunk driving, you need to come up and you tell them why. Because sometimes people do not take things seriously until they have tangible evidence. So we need to call upon all the stakeholders. That would be the community, the drivers, the border riders, pedestrians, Ministry of Works and Roads, because like today, an example of today, there was flooding in the city, and it has left many people with accidents still. And that is something beyond most of the people who are behind the wheel. It's more of an infrastructural issue. So when we start to advocate for this, we need to first of all look into the data. Right now, the data I quoted from Lago was done in 2019. So a study which was done in 2019, I think that's like 6 years ago, we've had cycles of over 6 new generations who are becoming road users, who are behind the wheel, they are becoming border riders. And right now, that shows us that we do not have the demographics, we do not have the causes and the outcomes for these TBIs. I know currently in trauma and neurosurgery generally, they feel they've done a lot of research on TBI, but we need to keep on updating. Because if you want to sit down with the Ministry of Works, you want to sit down with the traffic police, you want to tell them, you know what, it's not, you need to be very vigilant about road safety. You need to present them with the data and to show them like, we need this to be there. Then the other thing, definitely public health leadership that involves collaboration with all the government agencies, and then community engagement, because why charity begins at home. Sometimes, like, you will find actually the young children hold their parents accountable, most especially if you don't follow the traffic rules. And if you've realized like you are in a public means of transport and someone is not driving or following the rules, you have to call them out when you know what you're talking about. But then most of the time, because people in the informal settings, they are not really informed. Now, when it comes to things like safety of the cars on the road, we usually see the police.
One minute.
Continue. I'm done?
No, continue. You have 1 minute.
Okay. So we usually will see the police on the roads during the festive season, during the time when children are going back to school. But what happens during these other times? And even when they are on the road, are they checking out for these cars? Because most of the cars are DMCs. Most of the cars do not have basic things like seat belts, you will find a car, you can clearly see it does not have brakes and it's on the road. So we need to have all the stakeholders on table and to strongly advocate for safer, strong road policies in order for us to be able to reduce the TBI incidents. Thank you so much.
Thank you, Jarina. I think you were going to sit here. You are going to get questions after the end of the session. Next speaker is Dr. Kasaga Brian, who is going to tell us about geospatial modeling for timely surgical intervention, a mode of health center for.
Oh, thank you. Yes, protocol observed. Good afternoon, delegates. I'm Dr. Kasaga Brian, a surgery resident at Makerere. I'm in year 3. So I'm going to present this work on behalf of my collaborators. The team is there, and we do not have any disclosures. So in the work that I'm presenting, we all have heard of the Lancet Commission on Global Surgery, the unmet surgical need, the 6 billion people that lack access to surgery, and of course most of these people are in low and middle income countries. And of course the economic impact of that, having that about 33 million people globally face catastrophic expenditures when they are accessing surgical care. And of course with projections that economic loss due to surgeries in the tunes of trillions, of up to 12 trillion. So these events, of course, in 2015 led to meetings, of course, that passed the World Health Assembly Resolution 68.5 to kind of put surgery on the forefront of global health. And of course, the meetings included production of surgical indicators, which are the 6 ones: access to timely surgery, workforce, surgical volumes, perioperative mortality rate, then also expenditure in terms of catastrophic and impoverishing expenditure. But of course, among those, I would want to focus on the first one, that is timely access to surgery. So we assume in our study that if you have, for example, a farmer who is working on a farm somewhere and a tractor, for example, knocks them down and they get a fracture. So how long does it take for this patient to get a stabilization of the fracture? So in looking at the first surgical indicator, the timely access to surgery, we measure the percentage of the population within 2 hours access to a surgical facility. And of course, the target that was set by the Lancet Commission on Global Surgery was around 80% by 2030. But of course, there are some studies that were done in Uganda, and the reality is that less than 25% have timely access, according to Albut et al. In 2016. But of course, when you look at these surgical procedures that are emergency, we're talking about fracture stabilization, emergency laparotomy, and a C-section. So we are asking ourselves, from the previous studies that are done, for example, in 2016 and 2011, are there any new updates in this information? So that's what prompted our group to do this study. So the limitations of the previous studies was that they use self-reported times, so which were prone to recall bias, and they use what we call the Euclidean distance, which assumed that people travel in a straight direction towards the hospital. So then also, they did not incorporate the different road networks and transport, the topography, the land cover, mountains, and other barriers. So here comes another approach that we thought of with geospatial modeling, using access mode, which is a tool which was developed by Ministry of Health to give more realistic estimates. So in our study, of course, why does this matter? We've talked about the LCOGs, the 2-hour benchmark for surgical access, and the golden hour, we know that in terms of trauma. So our objective was to determine the 1-hour and 2-hour surgical access to emergency surgery for the bellwether procedures, and then to also model the impact of upgrading health center force to perform bellwether procedures. So we use quantum geographic information systems and accessibility study. And in this study, if a patient is going to reach out to a facility to seek surgical care, they are going to jump through a few hoops. So the first one is the land cover. They may go through a forest, or it may be a terrain, or it could be somebody's garden. Or there may be other barriers to movement. It could be a wetland, it could be a river or a lake. The other one could be the elevation, so they could be living on a slope like in Chigezi. There are many hills, or they could be in a place where it is very difficult to navigate. So then also it depends on the health facilities that are present. Where are they located in relation to where the patient is coming from? Then also we looked at the population distribution. How is the population distributed in relation to the health facilities that they are going to seek the facilities? But of course we know that where you have dense population, most times you have more health facilities. So then the other one is a travel scenario. Are they going to use a boat, like today some of us came in boats? Or are they going to use borders? Or are they going to use a car in that case? So that's the travel scenario. So using all this information, of course, we know the terrain can have a very big influence on the ease of transport to the health facility and, of course, in accessing surgical care. So in our modeling, as you can see, if that's the health facility, it always has a catchment, but it's not clear-cut. So you also have to look at the different items I've talked about, the terrain, the mountain, the road that you're going to permeate, or what we call the anisotropic movements. That means the degree of elevation or depression. So a patient, if it is a car, it will take longer if it has to climb a very steep slope than if it is just sloping down. So those are the anisotropic movements. And then also, it depends also on the capacity of the center to treat the target population. So, and of course, it also will depend on the type of transport you're going to use. It could be on a national, maybe highway, and a car can travel at 80 kilometers per hour, or it could be on off-roads, which are where they are not so good, and Maram, and they're traveling at 15, or it could be in forest and patient has to walk. You can't use motorized transport. So in so doing, we put all this information into access mode, which was a tool developed by WHO to determine access to surgical care. But we are, in our study, so those are the geospatial data sets. We use the coordinates of the facilities, the population distribution, the road network. We use the road boundaries, the rivers, the wetlands, land cover, and the elevation of the land to put in this model. And of course, to get a national expertise on the travel scenarios. This is one of the information, the graphs that I got from that tool. But specifically for Uganda, where we got our data was from the National Health Facility Registry. The population data was got from World Health Organization. There is that site there. And the road networks, we got them from OpenStreetMap on Google. And the land cover, we got them from Copernicus database. For the travel time models, we use two models. We assume that what if a patient is walking towards the health facility, then the other model is the bimodal model, where a patient has to walk towards the road and then afterwards access a means of transport. Now then also we made a comparison, what we call the baseline versus the expanded scenario. The baseline, of course, we know that most of our surgical care, we get it from national referral hospitals, district hospitals, and regional referral hospitals. And very few of the health center FOs do bellwether procedures. And so in the expanded scenarios, we looked at the impact of, what is the impact of adding health center FOs. So we put in this data, and this was the experts panel. We consulted the Minister of Health, and there was a stakeholder meeting that gave us the different travel speeds. And when we put into that model, this is the data sets for Uganda. This is land cover. This is the road network, the different types of roads. And in the results, in our model, we use only government facilities. And of course, there were health center FOs and those district hospitals, regional referrals, and national referral hospitals. So this is the travel time raster that we got from the access mode. And from this, we calculated the percentage of the population that can access surgical care. Within 2 hours, for main hospitals, the 2-hour surgical access was 20.4 if patients are walking to hospitals, and 1-hour access was around 9.7%. With health center force.
1 minute.
Okay, so let me summarize. I request 1 more minute. With health center force added, we saw that 2-hour access increased to 37.9. And to show this, these are the different districts in Uganda and the population coverage. And of course, with the addition of health center force, we saw that the access to surgery improved. But of course, also basing on the model, when you walk to the to the road and then you use a motorized transport, we saw that there was an increase. Within 1 hour, it increased from 74.9 to 74.9 to 91.6. Then within 2 hours, it increased from 96.6 to 98.7%. So these are some of the graphs to show an increase in accessibility. So the main takeaways from our results is that for the northern and western region, we saw an increase in 1 hour, the golden hour access to surgery of over 20.65 and 26.93% when we incorporated health center force into surgical access. Lastly, I wanted to just, maybe the strength of our studies that we consulted Ministry of Health for the expert analysis of travel scenarios, and then we assumed, but the limitation is that we did not include private health facilities. The policy implications of this that probably we need to build an emergency response, that's ambulance services, to enhance traveling patients towards hospital faster, and also strengthen health center force as surgical hubs for bellwether procedures. So I'd love to acknowledge my team members, especially Professor Galukande, and Dr. Elobu, who inspired us to work on this work. Asha Nagawa, who is a medical student, we collaborated on this work. Dr. Julia, who helped with the critique, and the other team from the GeoHealth group, Professor Nicholas Ray, Rick Lubas, and Andrew Curtis. Thank you so much for listening to me.
Thank you so much, Brian. I think members, I realize we are going to have next our keynote speaker, but as it is a tradition, we don't have questions after the keynote speaker. So I would give the audience a few minutes, or if you have any questions you have to the presenters. The two papers which have been presented. Anyone who has any questions? Dr. Kobusinje, can you get a microphone?
Because the Ministry of Health does supervise all those facilities, so that the information should be available. I'm wondering why you excluded them.
Yeah.
Maybe you can wait. Any other questions so that you get? I think I can respond to that.
Thank you so much, Dr. Kobsunje, for that question. So in our model, of course, we can also consider that scenario, but we thought in this model, we should look at government facilities which ideally are free of charge, and the patient can easily access surgery from most of these Ministry of Health facilities. So probably, yes, thank you for your suggestion. Probably we can also do another model incorporating private health facilities. Probably it could also give other insights. Thank you.
Dr. Jackie Mamujano.
Thank you, Dr. Nasozi. I wonder whether you've considered training border riders in some way or the other. I know some of them have some associations, because you mentioned it several times in your presentation, how they are really like a big burden or cause of the traumatic brain injuries in Uganda. I know together with the Neurosurgery Association of Uganda, have you thought about it? Because I know they are a big cause. I don't know whether they are also the victims, but then they are also a big cause of the incidents or road traffic crashes which lead to traumatic brain injury. Thank you.
Okay, yeah, so when we are doing community education and informing the community, they are part of the system with their leaders. So most of the time you have to reach out to their leaders and you have to also explain to them. The biggest issue with border borders is they do not have like proper training. What happens is it's usually more of like someone will come on the stage and then he starts riding around the motorbike. He doesn't know the traffic rules and everything. Then the next thing is they will just get on the road, and that's how they end up causing accidents. So like through informing them and also through having, like teaching them about road safety, road user signs and everything, yeah, that has been thought about. Now also the other thing, when we go still to the communities, we have to teach them how, most of the time when an accident happens, it's the people around who will be the first responders. So we have to teach them how do you handle a trauma patient, because they actually do more harm than good. They are not meaning really harm, but because there is some level of ignorance, so they end up causing more harm than good. So, and I would like to talk about Tanzania has done a very good job with pre-hospital care for trauma patients, and it has been through having they have what they call the chiefs. I think those are supposed to translate to chairpersons to our side. So they usually hold all these teachings so that they teach the community how do you respond, how do you remove someone from the wreckage and all that. So that also has helped them to decrease on all the polytrauma fatalities. Someone who would have sustained more injuries while being removed from the wreckage ends up not sustaining them because people are aware of what to do.
Thank you very much. I think the presenters deserve a big round of applause. Thank you very much. I think you can take your seats. Without further ado, I would like to invite our keynote speaker. That is none other than Professor Emmanuel Makasa. Actually, it's been informed is Mukasa. So, Professor Mukasa, you are welcome. I think it doesn't deserve any more introduction. He has already been introduced. He's going to tell us something about toward universal health coverage, strengthening health systems for surgical health care.
Thank you. Good afternoon, ladies and gentlemen. All protocols observed. Yeah, so this afternoon we're going to discuss the topic of how we can move towards universal health coverage by strengthening surgical systems. And I would like already to start, Chair, if you allow me, that I may switch between surgical or perioperative healthcare. For the reasons that, like I said, if we really are going to achieve universal health coverage, then we must really take care of the equity part of the progress that we want to make. And equity requires that we attend to those that need whatever we are trying to do the most. And those are mostly the people in the rural areas, especially at the lower levels of care in primary health care, which then brings in the issue that when we talk about surgery or surgical, most of the time people want to think about what we do in the hospitals only. But if you really want to address the surgical patient, then you must also consider what to do for the patient in the community. So the pre-hospital part of it is really important as the intra-hospital, and of course the post-hospital part of it, which goes back into the community. So for us to really be comprehensive, we must talk perioperative. And in the Republic of Zambia and in SADC, that's the language we are adopting so that we are more comprehensive and also aligned with a lot of other policies that we have. And I'll mention some of them as we go. I obviously chair the SADC Technical Experts Working Group, and I run the Regional Collaboration Center for SADC. And I've got a lot of working relationships with all those entities that you have seen there. So here I'm just declaring my interests and relationships. I have no conflict of interest except that I'm always interested in trying to ensure that everybody can have the surgical interventions that they need without having to face any catastrophic costs. So in this presentation, I'm mostly going to focus on the how-to. I have framed it more to be some kind of policy advisory. The how-to is basically, how do we translate political commitments, which are in form of resolutions or decisions that we pass at intergovernmental platforms, especially at the UN through the lead agency, the World Health Organization, into service delivery that actually touches the person. How do we do that? And these resolutions and decisions, as you know, they're not only at the UN. We pass resolutions and decisions at the African Union. We pass resolutions and decisions at the EXA, Health Community, East, Central, and Southern Africa, and of course, a lot of other platforms, including WHO Regional Committee through AFRO. So it's very easy to pass resolutions. Of course, there are challenges about how you negotiate resolutions, but how do we really translate this is always the missing piece. And that's actually what we need to know. How to do it, how to convince others, how to ensure that we can ensure the patient receives the care that they need. Now, there are many resolutions. Here, I've only used the World Health Organization resolutions. Like I said, there are others that we've already passed on this topic in EXA, in SADC, at AFRO. And the resolutions are many. Like I've said, I've listed a few there. Of course, the Global Action Plan for the ECHO resolution is missing. It's a decision that was passed last year in 2024. So if you were to look at any of those resolutions, you will see that there are components that touch on issues of surgical care or perioperative health care. The one I've highlighted, 6815, is obviously the best known resolution, which was very specific and said strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. So through that resolution, all the 194 member states endorsed and recognized that surgical care or perioperative care is part of universal health coverage. And without improving that, there can never be universal health coverage. Now, in the high level decision, that also was on universal health coverage in 2019, the surgery that is mentioned, obviously you just see one little word in paragraph 2035. But this, again, was just to highlight that even in the high level decision at the UN in New York, issues of surgery still remain very critical in the acceleration. Now, this meeting was called to try and see if the countries or governments could mobilize their support to try and do more. Because as you know, we are inching closer to 2030. It's 5 years away. This is 2025. So it's not too far away. And if you ask yourself, how much have we done? Have we really made any progress towards the goals that we set for ourselves in 2015? I would like to hear from you. What do you think? Anyone? Personally, I think that we haven't moved much. We're really very far. 5 years is basically just one plan for a government. Governments usually make plans in 5-year, periods. And so we're remaining with one chance to do something more to ensure that we can accelerate. In fact, that's why you see me talking about accelerate. It's not walking or moving towards UHC. We must try to run faster towards the finish line because we're remaining with very little time. Now, let's do some definitions so we understand what we're doing. Universal health coverage means, good health and well-being. In other words, it said good health and well-being for everyone. But if you break it down by the definition, it talks about 3 issues. It talks about equity in access. Equity, not equality. There's a difference between the two. Equity means those who need more, you give them more to bring them to speed. Equality means you give everybody the same thing. And in the delivery of surgical health care or perioperative care, we must use the aspect of equity. There is no equity in the delivery of surgical services. Like I said, the lower levels of care are not getting any service. The poor, the people in rural areas are not getting any service. So even in our process, in our progress to try and get universal health coverage, if we're going to do it equitably, we must prioritize those people. And that's why in my presentation today, I'm not going to be talking about what happens at Mulago Hospital Chair. I'm going to talk more about what happens or should happen at the district hospital and the rural areas. Now, goal 3, And UHC is actually target 3.8 of goal 3 of the SDGs. So it's part of the SDGs. Now, goal 3 itself is foundational because none of the other SDG goals can be attained without good health and well-being. So it's really foundational. If we cannot achieve anything in goal 3, I don't know if we can achieve anything anywhere. For us, obviously, in SADC, even if we get to 2030, we will continue to work on this. Even if the world decides to change, obviously they're going to meet up and come up with some other things that they're going to set for themselves as a world body for development. But for us, development is not going to come without good health and well-being, and we will continue to work on this, even if the nomenclature or the targets change. Now, if you relate what universal health coverage says and the situation that was painted as far back as 2015, you obviously can see that we cannot really achieve universal health coverage without that. 5 billion people lacking access to safe surgical health care. How can you say the world can reach UHC or Africa can reach? And most of those people actually are in sub-Saharan Africa or below the Sahara Desert, which is us in our region. So there's never going to be any universal health coverage for us with such statistics. And I doubt that the numbers have changed much because we are still in the process of formulating our national surgical plans or policies and developing the programs. So business has continued as usual while we are trying to set up the roadmap and skeleton frameworks that can help us to start closing the gaps. The backlog of people who need surgery is very big. The additional surgeries that are needed is huge. In our systems, when you go there, you find that the waiting lists are very, very long. And it's not only waiting lists for actual surgery, even just for outpatient care. The waiting lists are very long. If you come to my hospital in Lusaka, the University Teaching Hospital, you may get an appointment to see an orthopedic surgeon, which is after 6 months. So the waiting lists are long. The need is big. Okay? And we also got evidence that investing in surgery is cost effective. The World Bank, through the DCP3 essential surgery volume publication, clearly made the economic case. So it's not true for anybody to say that it's expensive to invest in surgery. It's not worthy. We don't need it. Only those that are rich can have surgery. Okay, and we all know through medical education, and I'm preaching to the choir here, everybody is somehow related to health. Even if we have journalists and media personalities here, I know that they understand. They know that surgery is it's a component of health systems. Even in medical education, you go through surgery as a rotation. It's a foundational part of your training. But in practice, how come it's only delivered in certain points, in certain pockets around the country, and the rest of the facilities cannot deliver surgical care? Surgery is an indivisible component of our health system, but we have not fully developed it. And obviously there could be a lot of other reasons. One of them is basically understanding the whole surgical health system and how it operates. This slide, again, like I said, in this presentation, I'm using a lot of material that has been developed by a lot of other people. This came from the Lancet Commission. Here I'm just trying to illustrate how access to care doesn't really exist in our systems. So if I put at the beginning there, I say country A, I can put my country, or I can put Uganda there. The first part about the timeliness of surgical care, which obviously has a lot of determinants are more outside the health system. They are in the other system. That's why, again, developing a surgical system is kind of complex because you have to work with stakeholders and parts of our society that are outside the health sector. That is to do with a lot of the patient decisions, transportation things, and stuff like that. But if surgery is not delivered timely, then there's no access. As you can see, it's self-explanatory, and you can keep going up to the top. Okay? There is the issue of the capacity. Sometimes the patient can come to the facility, but the district doesn't have the capacity to provide surgical care. So obviously there's no surgery, even if there's a hospital. Okay? The hospital may have, maybe the capacity may be available, but the surgical service is not safe. As you know, most of our surgical operations, especially in the lower levels of care, is not provided by experts, trained experts. We're not saying that the surgery provided by non-experts is bad, but that's why they're non-experts. We cannot totally trust everything they do. They need a lot of supervision. They need a lot of capacitating. And there is also what they can do. Our clinical officer colleagues cannot do everything that you can do as an expert. And so we also know that there is information in our countries that most of the surgery that is being performed is not safe because the demand is so high and the people to deliver the care is so little, such that people do whatever they can do, sometimes for the money, because it costs a lot of money, by the way, to receive surgical care. Most people have to pay a lot to just receive the care, and it's not even safe. If the surgery being provided is not safe, obviously, there's no surgery. And like I said, sometimes it's also, the cost is very high. So all those things in this infogram is very applicable to our situation when we apply to access. So it's not good enough just to have a hospital. Or you can have everything else, but if your patients cannot get to the facility, it's not your fault as a health system, of course. But if they can't get to the facility, there will be no access. So the access issue, obviously, this infogram explains it very well of what we face. Now, we had studies that were done in our continent through a snapshot by the South African team, the ASOS group, and you can see what they have shown there. 1.2 billion of the 5 billion people live in our continent, and 95% of these do not have access to safe surgical health care. That's big. So you can see, out of the people lacking access to surgery, the whole red piece belongs to us, sub-Saharan Africa. So we are affected the most. Again here, like on the issue of safety, ASOS also found that out of our patients, you know that when you look at the patient of Africa or sub-Saharan Africa, the young people are the majority. Okay, they probably make up more than 50 or 51% of our population. So our young people, normally they should be quite healthy. Young people are always much healthier and they recover much better. But when we do surgery, we lose our people much more, even in the perioperative time, more than people in the Western world, where we have people in their 70s. Look at the population of Europe or the US. It's full of old people who we expect to have more complications from surgery. But we are seeing more complications in our people than they are seeing in the old people. Obviously, there's something wrong. We are failing to rescue. Our monitoring and everything, even where we are providing surgery, it's not really safe. Again, like I said, this was just a snapshot. You can imagine if this was more detailed. Now, for all these reasons, that's why surgery was prioritized by governments, by you yourselves, the people working in the surgical space. For governments and for everybody, obviously, health is wealth. Most of us don't know that. So in our life, we prioritize houses, motor cars, and things like that. Rarely do we really think about our own health. Most of us we don't even have our health insurance, but we have the Mercedes-Benz. I'm not lying, am I? Yes, we don't look at health as anything, important, but health is wealth. If you're not healthy, nothing else matters in your life. You can go ask the people who are almost dying. If there was anything that they would pay for, they would want back, it's their health. They can give up anything that they have for health. It's true. So we must start thinking and prioritizing individually. It starts with us as individuals. We must start prioritizing health because it's the first, when we're talking about wealth, it's the first thing that we really must invest in. Okay? I've already made the point that with the statistics that we have just shown here, there is no way we are going to attain universal health coverage if we don't address the surgical needs of those 5 billion people who lack access, or is it 95% of the 1.2 billion that live in our continent? Now, the whole process somehow has been challenging also because when we start looking at the surgical systems or improving the surgical system, it is cross-cutting. It does not sit in one place. It's very difficult. Most of the time, our health systems have been developed with vertical programs, TB program, malaria program, HIV program. They run from the Ministry of Health to the facility. Sometimes they just need the physician, a lab result, and they can solve it. But for you, as a surgeon or people working in the surgical space,
Me alone, I can't do surgery. I need the anesthetist, the perioperative nurse, the porter. It's a team. It's not possible. I can treat malaria alone, but I cannot operate on a patient alone. Okay, there is surgery in every aspect. Like I said, in primary healthcare, there is surgery at all levels of the system, even in the community. So it's a vast program or thing that we want to address that is very cross-cutting. So it's complex. And because it has a lot of actors and stakeholders, sometimes it becomes a little bit problematic and difficult to do. But we are determined to ensure that we can solve this, because in the SDG era, we really want to work in a horizontal way. If you look at the MDGs, which is the top infogram, those things were very vertical and very, very specific. In the SDGs, everything is really connected. Now, but we think that in the complexity of the SDGs and in the complexity of trying to strengthen a health system, so what do you start with? Because the health system in itself is very complex and very detailed. What can you start with? So we propose that starting with surgical systems or surgical care could be a magic bullet that a country could use to accelerate the progress towards universal health coverage. And in this presentation, we'll try and go into a little bit more details. These slides, I'm just showing you the other things that improving surgical care can impact in the SDGs. So it's not only impacting universal health coverage. There are other targets that I've shown here. Forgive my poor eyesight, that's why I'm wearing glasses now. I'm becoming an old man, you can see even from my beard. But there are several targets on NCDs, reducing death from road traffic accidents, and a lot of other targets there that we have on the SDGs. We'll share the slides that will be impacted by improving surgical health care. Even when it's customized to children, again, the SDGs have got certain targets that are very specific to children. The improving surgical health care could also impact them positively. So surgery, like we say, can impact more than just universal health coverage in the SDGs. Now, I'm going to talk a little bit more about why surgery, how does it really help us out? First, I already talked that let's start thinking comprehensively, so we don't only talk about what happens in the health system proper as we know it, meaning we only go up to maybe district hospital, because usually there is very little operative care or cutting that happens in the clinics, maybe incision of abscesses. We must go beyond that. All other programs have even got health promotion, health education programs in the community. Our community doesn't understand or doesn't know what is a surgical condition. And that's why they like to go to papas for prayer for a cancer. It's obviously something that is surgical, but they don't know what it is. Sometimes they think it's witchcraft, or they will think that prayers are going to get rid of it. Our community lacks information about what is a surgical condition. As global surgeons or people working in the surgical space, let's think up to that level. So we have to go beyond what we always traditionally know as health. We must go into primary health care. We must go into health promotion, health education. We must partner with the media, because we need to educate our population, and we also need to know the real burden of disease. The Lancet Commission did a good job, but that was mostly made based on models, mathematical models. So it's not accurate. The picture could be bigger. As you know, when you're building a mathematical model, it depends on what input you put in, isn't it? If you have got, how much research comes out of sub-Saharan Africa? Very little. So when they put those things, even WHO information is based on modeling, mathematical models. It's not accurate. So if you're putting in very little accurate information, whatever you're coming out is just dreaming. You're just dreaming. It's not the truth. We must try to understand the true burden of surgical disease, even in the community. And we also must play a role in educating the community to understand and take responsibilities for their own conditions. Because, like I said, one, they don't know what they have is a surgical condition, and sometimes they don't even know where to go. They don't understand our systems. There is a lot of delays within our system. A patient comes with a surgical condition, paracetamol, go back home. Tomorrow, Brufen, go back home. Tomorrow, go to the next facility. By the time the patient gets to you, the cancer is stage 4. Because you were just playing around. You didn't know how to transfer the patient and ensure the patient gets to where they need to care. So the problem is not only up here. The problem goes the way down to the community. We must ensure that we can play a role and ensure that surgery can play its equitable role in improving the health system, starting from the primary health care. Now, surgery, like I say, I've talked a lot about primary health care. These are a few conditions that we've mentioned just to show you the cross-cutting nature of surgical care. It's important in the primary level of care. When you are managing non-communicable diseases like diabetes, cancer, injuries, surgery plays a key role. In maternal health and women's health, surgery is very, very key. If you're dealing with congenital abnormalities that impact young people, in our settings, surgery, we don't only talk about surgical site infections, but we have a lot of infections that are surgical conditions, abscesses, pyomyositis, chronic osteomyelitis. I can keep going on, and septic arthritis. Those are infections. But the treatment or the management includes surgical interventions. Okay? There's a lot of other surgical conditions, and even when we talk about emergency preparedness and response, we use a lot of surgical tools and protocols, even when we're talking about an infectious disease. Here, I'll give an example of the just ended, pandemic, COVID. What did you use to, first of all, protect yourself? I saw the lady, my sister was wearing a mask. You saw the mask she was wearing? We used to wear masks, isn't it? To try and prevent transmission between ourselves. Where did the mask come from? It came from the surgical space. The ventilators, pulse oximeters, the critical care personnel to intubate and keep the people who are really sick alive. Where did those come from? They came from the surgical space. Without our tools and our expertise, a lot of people would have died from COVID. Now, that's an infectious disease. But there are other hazards. There is wars going on. There is natural disasters, earthquakes. When those things occur, the first team that is sent out there is surgical, to go and make sure that those who are injured are kept alive before we even bring in water and sanitation. So surgery is very critical and important for emergency preparedness and the response to all hazards. So you can see it plays a key role in every place. And so it becomes a nice tool that we can try and use. Now, to provide safe surgery or to improve surgical care, obviously we must close the gaps that we identify in the building blocks of the health system. Here you've seen the building blocks: governance, workforce, health information, infrastructure, finance, service delivery. Here you've seen we've expanded it properly at PASHEF, because again, when we talk service delivery chair, people like to think about only what we deliver in the hospital. Service delivery talks about prevention and rehabilitation of those that are coming out of our facilities. So when we talk service delivery, or we talk about that pillar or assess it, when we're trying to develop our national surgical plans, we must assess the prevention part and the rehabilitation part. Let's not only talk about what we deliver in the facility. Now, to be able to provide safe surgery, there's a lot of other things that must be in place. And that's why we say it's a good piece to strengthen the health system. I've already shown how it can deliver good health outcomes in different areas of work in health. So we cannot provide safe surgery without good laboratory support, isn't it? We can't operate on you if you don't know your hemogram, your urinary function, and a lot of other parameters, your heart function. Before we do operation, we have to take you to the physician to do an ECG and a lot of other things. Okay? So without laboratory support, we can't perform surgery. So good lab support is mandatory for surgery. And it's not only the surgical patient that's going to benefit from that. All the other patients in the system will benefit from it. But if we improve it for surgical purposes, other patients will still benefit from that. I've already talked about imaging. We do a lot of X-rays, CT scans, and a lot of other ultrasounds in surgical care. In orthopedics, it's mandatory. We can't do anything without looking at the bones somehow. So by improving the imaging system or imaging capacity of a facility for the sake of providing safe surgery, we are also doing it for every other patient, and the system becomes stronger. We use a lot of blood and blood products in surgery. So we need to know how to screen the blood to make sure we have good blood. the supply chain should be good, and how to maintain the cold chain and everything like that. Again, it's not only the surgical patient that relies on good blood transfusion services. Referral systems, again, sometimes we have to rush people between facilities so that they can receive the care they need in time. But if we can improve the referral system for the surgical patient, all the other patients will improve. As you know, most of the time we're even leveraging maternal health. There's a lot of investment on referral system to try and transfer mothers, because the mothers come to a facility and they can't deliver and they need a C-section, they're almost in the second stage of labor, and we have to rush them. But because of improving that service, other patients will also benefit from it. Okay? Rehabilitation and palliative care, we need it in surgical patients, but again, if that system is improved for surgical patients, it improves everybody else. And of course, information management. We generate a lot of information. Actually, this is where the biggest gap is for us. That's why a lot of things about surgical services are not known. We always write in the patient's file, we always write in our theater registry, but this information stays in the paper-based platforms in our theaters. Very little of it is actually transmitted up to the decision-making platforms. So when you ask a country about a lot of statistics about surgical care, they are blank. They don't know. It's not because the information is not there. It's because we are not managing that information properly, and that must be improved. So we're thinking of digitizing information for surgical patients. But again, like I said, we cannot do it for the surgical patient only. Because the surgical patient is a mother. The surgical patient is a child. The surgical patient can come from any other part of the health system. So by improving it for that, for the surgical patient, we're improving it for everybody else. So you can see that to deliver safe surgery, you will need a lot of other things that you must put in place, just for one patient even. And by doing that, you are strengthening the health system to deliver better health outcomes for all other patients. Now, surgery also doesn't only impact us in the way I've explained it, it also impacts the individuals themselves. Remember, I talked about health being wealth, but also health enables to break away from dependency. It saves lives, it reduces mobility and disability. There's a lot of disability, especially in surgical conditions. Just because of a myelinated fracture, I can lose my means of earning a living if I'm a subsistent farmer. When a fracture, maybe I can even fix it. If it's something that requires open reduction and internal fixation, I can fix it in 2 hours. But somebody is poor for 5 years because nobody could provide them the care that they needed in 3 hours. So if we really are bent on trying to develop our countries, we must invest in things that help the people to become independent and productive. And surgical interventions are one very sure way that can ensure that a person becomes productive. Even their family becomes, they stop relying on their family. It has impacts on the family, on the community, and of course, on the country. Now, we as global surgeons or people working in the surgical space, we must also start looking at how we can do research in collaboration with health economists and others, because this is the language of government. Governments invest to ensure that they can have a productive population and develop the nation. And like I said, people look at health as a waste. So we put money in health, and it's like it's a bottomless pit. They never really see what can come out of it. It's research like this, the socioeconomic impact of surgery, that we must be doing as well. So we can show the bang for the buck that they invest in surgical care. Now, to be able to translate these policies, like I said, first of all, you need a plan. The permanent secretary here was telling us about, give me something. Give me a strategy, give me a plan, so I ensure that it's integrated into the sector strategy and contributes to the 4th National Development Plan. That's what she was saying in the morning. That's the very sure way of having any investments. Nobody can invest in anything without knowing what you are going to get out of it or where you are taking the money. I would never give you any money of mine if you don't tell me what you want to do with it. So if we want investment in surgical healthcare, we must make a plan. We must make a strategy and show clearly what's our objective and how we're going to do it. And so policy formulation and implementation is one part. But the policies that we formulate must be aligned. Aligned with what? Aligned with the sector strategy. Because the sector strategy talks about what the government is going to prioritize for a certain period of time. So here, like she said, if this is done by this year, starting from next year up to for the next 5 years, only the things that will appear in the health sector strategy will be funded by government or their partners, because their partners also look at that strategy. So there is a saying in Zambia, or well, we like to say it in Zambia, which says, opportunities favors those who are ready. So you must get ready to get favored. So I'm saying it here again in Uganda. Opportunities favor those who are ready. Get ready to get favored by try to accelerate and complete your strategy so that there is alignment and inclusion. Okay? Now, there is also integration of the programs that we come up with. So it is integrated in the National Health Strategic Plan, but there is also another part that we have left out most of the time and we're just learning now. So WHO comes up with the essential health package, the possible things that you should be able to do to achieve universal health coverage. But every country then comes up with what they call the National Health Benefits Package. This is the package, the minimum package of services that they can afford for that time. Obviously, they can keep adding to it depending on the growth of their budget. Now, when you look at the documents, several countries have got that basic package of benefits package. When you look at those documents, you realize that surgery does not exist. It's not there. So if it's not in the basic package of services, how do you think it's going to be done, even if you have the national policy? Like I said, in Zambia, we had a policy from 2017 to 2021. We did very little. One other reason was because there were no surgical interventions appearing in the basic package of services. So while you are trying to align your strategy to the national document, also look at what's the basic. Because this package defines what you deliver at every care level. So at the clinic, we're going to do this. At the district hospital, we do this. That's what we can afford. So I'm challenging you, don't only focus on your national surgical plan. Try look at your benefits package and see what is there. And recommend to government what you want to be done as a minimum at the different levels of care. Unless you do that, again, it can be aligned, it can be national strategy, but in the benefit package is not there, nothing will happen. Because even the facilities, they budget based on what is in their basic package. As a hospital, this is what we say we can do, we were recommended and we are funding for that. Okay? I've already spoken to the issue of primary health care. Chair, I hope I'm staying within time. I talk a lot. Please remind me if I'm going beyond time. Now, like I said, the whole drive towards universal health coverage mostly focuses, for clinical services, on the district hospital. We also know that in our health systems at country level, the district hospital is the elephant. It's the facility that's not delivering what it's supposed to do. It's the facility that's closest to the population. It's also the facility where we can do the basic of what we call the bellwether procedure. The district hospital should be able to do a laparotomy, open laparotomy. We're thinking we can go laparoscopic, yes, but you should be able to do open laparotomy. You should be able to stabilize an open fracture. You should be able to do a safe cesarean section at the district hospital. And of course, when you look at the other UHC things, they focus mostly on the district, because we've known that in the district hospital, in the health system, patients come from the community, they may go to their clinic, but most of the time they skip both their clinic and the district hospital, and they come and congest Mulago Hospital. So everything is coming to Mulago, abscesses, closed fractures, anything. And then there's congestion, and then everybody's complaining, the workers are overwhelmed, government complains you're not doing your job, because the district hospital is not working. We want the district hospital to be able to function so that they can deliver care to the people closer to their community and earlier, because it costs a lot even for the people to travel all the way to the capital. There are non-medical costs that they are going to incur. They don't know the facility. In fact, sometimes they don't even want to come, because just coming to Kampala is overwhelming. It was overwhelming for me. So let's capacitate the district hospital so it can deliver the care that it needs, and that's our focus when we do this. This infogram, again, I'm just trying to emphasize the issue of perioperative care, which splits the pre-hospital, intra-hospital, and post-hospital. Most of us, most of the time, speak about the intra-hospital. As we try to formulate our policies for UHC, let's not forget the pre-hospital part of it and the post-hospital part of it. They are really, really important. Patients come to the facility only for a certain time. They come from their community and they go back within their community. So let's ensure those services are appropriate and are also improved. Now, this map just shows, again, the process of how we develop a policy or a plan at country level, or a national surgical obstetric anesthesia plan. Most of you have seen those stages already. I'm just showing this to emphasize two things as you develop your policy here for UHC. That the development of your policy must be inclusive of all stakeholders, especially the community. Every stage of that process should include the community. In Zambia, the first policy we developed, we left out the community. And so we didn't even know their needs. We always assume we know, but we are on the supply side of things. Maybe their problem is just the attitude that we have as health workers. We must bring them on board so we hear what are the gaps, what are the challenges they are facing with the system. Because it's a plan for all of us. And let's not forget that sooner or later, we are also on the patient side. I had to undergo a laparotomy myself some time back when I came from Geneva. I was lucky because I knew everybody. I just had to pick a phone call, blah, blah, blah. Within 3 hours, I was on the table. But we just did a study in Zambia, in Lusaka, to look at emergency laparotomy. You know the waiting time that the patients have to wait before they undergo surgery? More than 9 hours. 9 hours having reached the facility. The patient is in UTH. They wait for 9 hours before they undergo a laparotomy. Me, I was screaming and insulting by the time it was already 3 hours because I felt like people were not saving me fast enough. So let's involve the community so we understand their concerns and bring them on board as we are developing these policies. And we also must think sustainability in these plans when we make them. Let's not make plans for the Western world to fund us. It's common knowledge that the financing system of the world is changing because all of us were relying on Big Brother. The money is not there anymore. Big Brother is calling us name and we thank him for it. We must look within. We must look within. Professor Agawa was talking to you that sometimes we're talking funds only. It's not just funds. It's just not money. I remember, I'll give you a quick story. When I was president of the Resident Doctors Association in Zambia, we were always fighting with government about our conditions of service. And every time we went to the government and we paralyzed the system with strike action, we were looking for money. We want money. We want money. One time we had to change a strategy and discuss money. So what do we need the money for? If they give us more money, what do we want it for? And then we realized, oh, I want land. I want a house. We wanted things that government already has. So all we did is change the strategy and went to government saying, okay, if you can't give us money, give us a piece of land in a district we want. And give us access to a mortgage at 0% so we can build the house. And you don't have to give us more money. Government was very easy to give us that money and was able to retain the doctors in the country. So it's not always about money. When we're thinking sustainability, let's look at all the resources that we have, but we must build that into the plan that we make. Now, the Pan-African Surgical Healthcare Forum is a platform that has just been created. The first one was 2 years ago. This platform was created to support the governments. It's actually a government-owned platform. The first 2 meetings were held in Rwanda, hosted by the Ministry of Health of Rwanda. Now, the platform belongs to government because Africa wanted to chart its own pathway. So create something for Africa by Africans. Because we, having worked in the global health community for a long time, we know that there's always hijacking of our ideas. We have a problem, we call everybody to the table, they come there with their own agendas. And they insert a lot of trash and hijack the whole process in the end. Even when we've talked about global surgery, the whole movement of the resolution started from here. But all global surgery meetings have been taking place in Geneva, in New York, in Rwanda, in London. There was nothing happening here. How can we be going to places like that with visa restrictions and costly exercises to talk about our problem? Why? So this platform was created that Africa can start solving its own problem using its own resources here on the continent. And the first 2 meetings were restricted because we did not want the thing to be hijacked. So it was strictly for governments, so the governments can come, agree on a lot of things, and chart the pathway. Afterwards, then everybody can come, after we've already baked our cake. So this platform is there to support Africa. Again, the idea is that we must share. We must share our expertise, we must share our experiences, we must share our resources as Africa if we're going to move forward. Because none of us has got everything that they need. But when we team up together, we make a very powerful team. And we proved this at the UN, even among us diplomats. So there's always value in working together, but you always have to be strategic on how you do it. The next PASHEF meeting, obviously, is going to be open to all stakeholders, but the baby or the cake has already been baked. Now, you should leverage this platform. I know that Uganda has delegations and had delegations coming to this platform. Leverage the resources and everything and the expertise that are on this platform to help you on your pathway as you move towards universal health coverage. Now, there is also the issue of not knowing what to do. So the whole issue of developing surgical care or developing a plan, sometimes we say it's up to the policymakers to do. Here, I just want to highlight mostly the 2 arrows that are pointing there. So the policymakers have got the responsibility to build and develop a policy, and they do it from the top down. But you, the surgeons, the health workers, also have a role to play in this, because you will come with the evidence and the expertise and the experiences from the ground that informs that policy. So it's not true to feel helpless and say, there's nothing I can do. With your research, if you disseminate it properly and you do it correctly, you're going to give us information that will be very critical in the whole process. So we can develop and ensure that we can give the right interventions at the right time to get the good outcomes. This map I share with you is just a map that shows the different stages of progress in the sub-Saharan Africa. Obviously, the key is kind of very, very small, so it may be very difficult for you to see. All I can say is that African countries are at different stages of progress in terms of ENSOP formulation and implementation. Of course, we have Senegal and Ethiopia that started this process way before 2015. We have the Republic of Zambia and now Nigeria that are revising their national surgical plans. And then the other countries are obviously at different stages. I'm more conversant with Southern Africa, so I can tell you that Namibia, Zimbabwe, and Madagascar have their plans already. The rest of the other countries are at different stages. Either they are in the early stages or they start and stop, so it's an ongoing process. And like I said, you don't have to be married to the acronym ENSOP. You can call your strategy whatever it is. In the Republic of Zambia, for the sake of inclusiveness and integration, we are calling it a perioperative plan or perioperative strategy, because we want to take care of the whole continuum of care. And we don't want nurses to start saying they are not part of it, or others who are not mentioned in the acronym to not be part of it. And also we want alignment with all the other policies, including the ECHO resolution, which talks more about surgical care in emergency situations or emergency preparedness, mostly focusing on critical care and emergency care. The inaugural meeting of PASHEF recorded those countries as attendees, but the last one was up to 42 out of the 55 member states of the African continent. The next meeting will be in Rwanda, and then Ethiopia will be the next host. So, ENSOP implementation is important, but you can go with an initial implementation. Once you have the policy in place, go with an initial implementation. Don't think that you can implement countrywide. It may not be possible. Choose a district, choose a province where you can do this. Now, that initial implementation is important because you want to generate the evidence, and you also want to demonstrate impact of the new policy. The impact you want to demonstrate is how it can help improve the health system. I've already tried to illustrate how this is done, or it is possible. How you can contribute to health outcomes. Here I can also give an example of maternal mortality during childbirth. The maternal mortality is not dropping. People have invested tons and tons of money, and it's still not dropping. And yet we have evidence that what kills mothers around childbirth is bleeding. You can't stop bleeding with paracetamol or a contraceptive. Yeah, you stop bleeding by surgical intervention, even if it's preeclampsia or eclampsia. You know the solution is to get the baby out, isn't it? Yeah, how do you do that? By praying? No. You have to do a C-section and get the baby out. So let's show how we can contribute to reducing maternal mortality by improving surgical care for maternal health. Even that is an impact to show. Because government and everybody is trying to do that. Like I said, let's also not only talk about health outcomes or health issues. Let's talk economics. How do we contribute to the socio-economic of the individual, of the family, of the community? Have you tracked all the patients you've operated on and seen how they perform economically after you've operated on them? You should. That's the impact that you can show that is much more impactful. Not the numbers of people you've operated. Show how you've gotten people back to work. That's more important. And of course, you're going to learn lessons from this initial implementation on how you're going to do it better, how you're going to revise the policy. Lessons are always important. Then you can then start the nationwide scale-up. How you do it, like I said, there is no prescribed way. You can just look at one facility with its catchment population, or you can look at the district with all its satellite clinics, or you can pick on the whole province with its districts in there. It's up to you. Now, to do the initial implementation, you don't need funding from Ministry of Health. You can get a grant, or you can put money together as a society and do that. Because once you have that evidence, impact, and lessons, it will be very difficult for anybody to argue against that, because you have real information from the ground. The key message is safe, timely surgical care or perioperative care contributes to saving lives and attaining good health and well-being, which is universal health coverage. Good health and well-being is important for economic activity in a country. Without it, nothing can move forward. And it's also an indicator for national development. So surgical care or perioperative care really can get a country to development. It's a masterpiece. Let's try and deliver this to the countries and to the people. Thank you, Chair.
Thank you, Doctor. Thank you, Professor Makasa, for this wonderful keynote address. It's always a pleasure to listen to you. I've been with you on so many global surgery lectures, and it's always inspiration to listen to you. And by the way, Professor Makasa was supposed to become a priest. Yes, and now maybe he would be a bishop preaching to us.
I would have gone for the Pope.
So you are welcome. Thank you so much. And it is a pleasure listening to you. I think MC. Yeah, maybe you need to take a what? Okay. Maybe the panelists should, rather the presenters should come, and maybe we share a picture with Professor Makasa. You are, please come over to the podium so that you have a picture, a photo with you.
Thank you so much, the chair of the session and the panelists. I think we can stretch a bit within the places where we are as we welcome our next chair, Dr. Felix Oyania, is he around? Yes, please come and take on the next session.
Hello, everyone. For the interest of time, we are going to have our last session. Having seen the important universal health coverage, this cannot do without surgical innovations. We'll take this session to do our surgical innovations. Our first presenter is Engineer Kato Hussein Wabi, who will present to us the development of a low-cost negative pressure wound therapy device for accessible wound care in low resource settings. Engineer Kato, you are most welcome if you're around.
Thank you so much, Doctor. Okay, thank you so much, Doctor. My name is Kato Hussein Wabi from the Makerere Biomedical Engineering Unit. I'm a biomedical engineer, and today I'll be presenting the development of a low-cost negative pressure wound therapy device that has been developed to increase accessibility to wound care in low resource settings. So to give a brief background before I start presenting our device, I want to recognize and acknowledge Dr. Brian Kasaga, who initiated this project. And Dr. Brian challenged the Makerere Biomedical Engineering Unit through Engineer Brian. So it was Dr. Brian to Engineer Brian. Yeah, so it challenged us with a problem of negative wound pressure therapy devices being effective, but they are too expensive for most hospitals and patients in low and middle-income countries. And when it comes to Uganda, the cost becomes too high, as we are going to be saying. So we ran into a mission to develop a cost-effective and clinically effective negative pressure wound therapy system that can be manufactured and used in our low resource settings. So the burden of chronic wounds globally, the statistic is 1.5 to 2.2 per 1,000 people. So globally it might be low, but when it comes to Uganda, we have higher rates due to increased rates of diabetes, trauma, or post-surgery infections. So this increases the burden of chronic wounds And negative wound pressure therapy has been proven effectiveness to increase the healing time by 50%, which significantly reduces the infection rates, and this decreases the need for repeated surgical interventions. But if negative wound pressure therapy is effective, why isn't it widely used here in Uganda? So the first problem that we have is the cost, as it is mentioned, it was initially mentioned by Dr. Kasaga, that the cost of developing this device, we found out that the system itself costs around $3,000 and above, and the dressing, or only the dressing, costs around $100. This makes the treatment a bit more expensive, and the end results, it makes more complex wound infections, and this leads to more amputations and longer hospital delays. So this brought us to our mission and objective to develop a cost-effective, accessible solution that could be effective for our low and middle income setting. And we had mainly 6 objectives that we are looking at. The first objective was to have our system to be affordable. So the affordability was to be measured with our system being a cost of less than $100. So we had to look at what increases the cost to be above $3,000 so that we can be able to make it come down to $1,000. And the other objective that we had is to have the system energy efficient. We know that our power outages are not that stable, more so in remote settings. So we need to use a 12 DC power supply, and this needs to be compatible with a solar system. So these are the things that we had to look at to be able to come up with a design criteria that we should be following. Also, the device has to be portable and easy to use. Portability makes the device being used in both hospital settings and home care, so that even if someone is discharged, they can be able to utilize our system even outside the hospital. Then it should be having a sealed dressing system and also having an automated pressure regulation to provide the negative wound pressure. So for now, the device that we currently have is regulated manually. We haven't implemented the automatic pressure regulation, but during the tests, we were able to get the pressures that were required to achieve the negative wound pressure therapy. And the other criteria that we need to implement our device is to have it locally manufacturable. So every component of the device, everything that needs to be on the system should be available locally, or it should be, if it's not available locally, we need to be able to see how can we have a supply chain that can be able to reduce the cost. So on the right, we are seeing our first prototype that was developed. It has the control knobs for increasing the pressure as well as the display. This is a proof of concept. So it went through the testing and it was more promising. And when we got feedback on the performance, first we did the pressure regulation testings where we got the feedback on the performance, and we made further improvements to have a version 2 of our proof of concept. This device is in the exhibition, so for those who go into our booth, the Makerere University Biomedical Engineering booth, the device will be there and it will be illustrated to you to see the functionality of the device. So currently it uses an LED interface where it has the control knobs for adjusting the pressure, and it has a 12 DC power supply as part of our design criteria, and it also has an integration where we can have the solar system integrated into the system, the solar compatibility being integrated into the system. Yeah, so we have done the testing, proved our proof of concept. We have made the different modifications, and the prototype development is still ongoing. So this is a system that is still ongoing, and we are soon to do more tests to see how can we improve the usability, efficiency, and safety of the device, and also increasing the pressure and suction performance evaluation so that we can be able to ensure consistency and the effectiveness of the device. As well as also in the future, we shall be able to carry out further clinical trials. And part of what we do in the biomedical engineering unit is exploring the regulatory pathway. We are working hand in hand. Part of the things that we have learned as we are developing new devices is working hand with our regulators so that they can advise us on the many different aspects. So even this device, however much it is in the proof of concept development stage, it is also getting consultation from the regulators to see how best we can fulfill all the requirements at hand. So that is our team, which is headed by Engineer Nakato Shadia, and I'm the co-lead and advised by Engineer Brian Matovo as well as Dr. Robert Sechitoreko, and our clinical lead is Dr. Brian Kasaga, who we have seen before. So the main message for this project that we have here is that problems are seen firsthand by the surgeons, but surgeons won't have the time to innovate. So having a surgeon reach out to the biomedical engineering department makes it easier for us to be able to see what needs to be given priority. So when surgeons and biomedical engineers do come to work together, we don't just design devices, but we rather aim to create cost-effective and life-saving solutions that can really advance healthcare and make it accessible to everyone. As Prof. Emmanuel has mentioned, we need to make our devices that are going to be used in our settings, because it's us who understand our problems. Thank you.
Thank you, Kato. Engineer Kato, you can take your seat. I can assure you have many questions because all of us, if not all of us here deal with wounds, so please come and take a seat. Yes, please. We shall have our next speaker. That is Miss Paulina Korekwa. Paula Korekwa, who's going to talk to us about a low-cost laparoscopy for surgery in low and middle-income countries. Is Paula around? Yes.
Okay, as the presentation is loading, good afternoon to you, ladies and gentlemen, all protocol observed. My name is Paula Korekwa, and I am a biomedical engineer. I was here last year. Most of the faces are familiar. Earlier on, Dr. Kakungulu joked that I'm almost getting honorary membership too. So I'm going to be presenting a low-cost laparoscope, which is known as the Keyscope. It's a collaboration between, basically between engineers, surgeons, business experts. So it's such a big team, and I'm a junior research fellow. As I said, I am a biomedical engineer by training, but to do this work, I have had additional certification in ISO 13485, which is quality management system for medical devices. So I'm very sure we all understand the global burden of surgical needs, so I won't go into that. And this speaks to SDG 3, good health and well-being. So the approach we took to designing was the human-centered approach, where we engage the user, the person that's facing the problem, so that we shall not do what we think in our heads, but actually listen and implement what we are told. So after designing, we often go back to our users and try to seek feedback and input and try to improve the device. So for this particular project, we've been focusing on local manufacturing, then trying to navigate the regulatory process for Uganda, and then proving clinical safety and acceptability through a clinical trial. So the device is a low-cost laparoscope, which, unlike the standard of care, is just a single unit device. Let's take a Carl Stoll's endoscope. You'll have these very delicate fiber optic cables. You have the light source on the tower, so this just incorporates everything into one. It has a camera at the tip, it has LED lights at the tip, which pulse to produce light, and it is controlled by a CMOS detector. I won't go so much into the engineering. Then, instead of insufflation through gas, it uses mechanical retraction. We are using mechanical retraction, and that is done through the key loop. And then the device is powered by a laptop, and image is to be viewed on the laptop screen through a custom-made software. So we've done, this project has been going on for many years, and basically today I'm just going to tell you what has been new from the last time I was here. I've personally worked on this for the past 4 years. So we've done benchtop testing where we were checking the optical parameters for the device. That is the illumination, color reproduction, accuracy, things like the depth of field, the field of view, and in all this we're just trying to compare our device versus the standard of care. Oh, that still results from resolution testing and color accuracy testing. Yes, so that's just images from our device versus the standard of care. So this device has also been tested in pigs, and for this study in pigs, it was done by 5 surgeons, where each was performing 3 tasks, and we were trying to assess the time they take to complete the tasks, and then also monitoring of the vital signs for the pigs. Those are the tasks that were done, and after this they were issued a survey where they just pointed out the things that they loved and those that they would need to be changed. So the results is there was no significant difference in the vital signs, no differences in tissue pathology. The things they liked was that it attaches to a laptop, although that would, so the laptop size screen is limited, so they pointed at that. Like, it's nice for it to be powered by a laptop, that even when there's a power outage, you can continue doing the surgery, but then the viewing screen is quite small. Then they loved the ergonomics of the handle, and then the color reproduction accuracy. Then they requested for an angled scope. This is just a 0-degree camera scope, so plans are underway to design the 30-degree scope that could be able to view at angles. In addition, we got conditional approval to conduct a first-in-human clinical study at UCI. We had a joint review meeting. I see very many familiar faces, people that were assessing our protocol. So it is, we've basically done the normal things, trying to get insurance for the participant, data safety monitoring, risk assessment. So trying to put all those things together, and I think we should be starting in around September this year. That's the goal. And the FDA recommends that first-in-human studies, feasibility studies, be conducted in 12 patients. So we are going with 12 patients. So what is our current work? Someone might wonder, what have we been up to? So the bulk of the work, rather than undertake the path of developing this device from elsewhere and bring it to Uganda, we tried to go the long and narrow way, which was develop the device in Uganda, try to source the materials locally, try to get local regulatory approval, and this is following international standards. So we have partnered with a local manufacturing company in Namave called Shishi International that has tried to get approval for a GMP certificate, Good Manufacturing Practice Certificate, from National Drug Authority. So the step before that, just before they give you the GMP certificate, they give you a license to manufacture. So we are just at the stage of getting the license to manufacture. And then we are also trying to CE mark the device. And you know, the CE mark is issued by the MDR, which is the Medical Device Regulations. That's European. And they have all this checklist of requirements that you need to fulfill. And we are trying to go through that. There's ISO 13485 quality management systems. The Still Shishi International is trying to pursue that. You would wonder, why are we doing all this? It's just so that the users can trust a Ugandan-made device, just to show you that something made in Uganda can be just as good, just as effective. So this is a call to join the Bubu bus, Buy Uganda, Build Uganda. So we've been doing a risk assessment. There's something known as the failure modes and effects analysis, trying to see how will the device fail. What are the potential hazards? How can we mitigate these risks? Then biocompatibility studies. This is a highly invasive device, so trying to ensure that there wouldn't be severe adverse events. And the biocompatibility studies, we've definitely hired a company abroad. There is no company in Uganda that could do the biocompatibility studies. Then sterilization validation. For the laparoscope, should be dipped in Sidex. So trying to see if you dipped this device in Sidex for 30 minutes, shall it actually be sterile? If it had, let's say, 100 cycles of sterilization, will it have reached its end life? Will it still be good to go? So this is part of the documentation that we are trying to put together. Yes, those are the references. And like I said, it's a really, really big team standing on the shoulders of really great giants. There's surgeons, there's imaging experts that are part of the team. And yes, we get our funding from Wellcome Leap and from the National Institute of Health. Thank you very much.
Thank you, Paula. I must say, as pediatric surgery, we have enjoyed collaborating with you. We hope this goes well. Please have a seat to take some questions later on. Moving forward, our next speaker will be Engineer Brian Matovu. He will speak to us about experiences in translating surgical device innovations in Uganda, the case of innovation at Makerere University Biomedical Engineering Unit. This session is interesting that it's only presented by engineers, but the surgeons are the ones who give you the ideas.
Right, thank you. Good evening, everyone. My name is Brian Matov. Okay, yeah, my name is Brian Matov, and I'm a biomedical engineer by profession, and I've worked on a number of projects in the Mac BME department. So I just wanted to share what we have in the department and briefly what we go through to have some of these innovations out, and then also to try to show what are the challenges, okay, that are there. Why don't we have made in Africa products made in Uganda, medical devices. I know Paul and Hussein have hinted about some of them, but I will proceed. So, biomedical engineering design is not all about research or craftsmanship. Okay, it involves some bit of discovery and design. So we do a lot of design, and we're going to understand what takes place in design. Okay, why is it that a lengthy process? Okay, and basically this design involves you trying to think about the ideas, okay, that you are having in your mind, or the team has. You're trying to understand the processes you're going to go through. Sometimes you need to bring in the re-engineering, reverse engineering to try to see, okay, now we have this in place. Is there a way we can replicate this in the country? Some of the products are taking that approach. Some of these are looking at systems as a comprehensive approach, trying to change the system. How do we manage health technology in our healthcare settings? Okay, but then we are being stretched to actually go into things of finances, things of entrepreneurship, okay, IP management, business, because at the end of the day, who is going to solve those challenges if we don't want these innovations to actually stop in the books and papers for students and etc. So we believe, okay, in medtech, okay, a prototype is really worth 1,000 pictures. Even if you have a nice idea, but if you can't put it to paper, if you can't put it to reality, we feel like you're just wasting your time. And we follow the Stanford biodesign process, okay, even in the curriculum that we have in our biomedical engineering for the undergraduate students. And basically, it all starts in the needs finding, okay, and we have different approaches for needs finding. We task faculty and students, mainly the students, we send them out in the hospital environment to actually interact, and this takes like a full semester, 3 months, okay, 4 months, of them going and interacting with the doctors out there. They come back with like 200 problems. We discuss them. Okay, each group. Okay, we discuss them. They start like from 200 until when they pick out one specific problem that they want to solve. But all the 200, they must have reasons. Why are they leaving them out? Okay. So we look at things of statistics. We look at things of who is being affected by the problem. Is there actually national interest on that problem, and so many others. So we do all that, and then that goes into a screening. But then there's also the point of concept generation. So this comes in mainly in their second semester. Okay. They first get the problem, and we ensure that they don't focus on the solution. But then we come to the solution bit of it. Okay. They also need to come up with so many solutions. They go into brainstorming. Okay. And some of the ideas that normally come in such sessions is we just sit in a room, you start thinking of what are the solutions to this problem, okay? Maybe it's PPH or anything else. Students think, some start saying, we pray to God, okay? We talk to the government. Like they put their brain to work for any solution that actually comes up. And this takes really a lot of time, up to strategic development, okay, and then business planning. Although we don't focus so much on the business side, for the curriculum, we end on the concept generation and testing, okay, and then some bit of redesigning on that. So it's not really an easy path, okay? There is a lot of interconnectivity that happens in there. You need to talk with the doctors. You need to, I will talk about briefly on the keyscope, okay? We need to interact with the doctors, the surgeons, and the other people that are really at the front line of most of these problems. But then you end up into looking at environment, what you're going to produce, okay, the materials you're going to use, how are they interacting. Professional associations also come into play, okay. The regulations, you don't only look at the local regulations, but you also need to look at international regulations. And then that's where we have a big gap. Local regulations are not in place, but then you need to go for the international regulations. But then when you go for international regulations, then the local regulators really don't understand some of these on how to go. So it involves a lot of stakeholders coming in place. And because of that, it's one of the reasons why medical devices are actually so expensive, because of the so many players that come into play. So at Makerere, we don't have really, for the Mark BME, we don't have many facilities that we are trying, but we are relying on us being in the Mulago National Referral Hospital, so we are really so close to the doctors, so we can easily have ideas bounced around, plus also the infrastructure that is really around. But mostly we have the design spaces, okay, which we call the design cube. So this is where the students and faculty go to put their ideas to reality. So it is equipped with basic tools, okay, of mechanics, okay, electrical, for them to come up with the basic prototypes that they need, plus also 3D printing and so many others. So this has really brought in a lot, plus also I want to go into the statistics. So some of the innovations that we have, one of them is the UV study device. This is funded by the government of Uganda. And it started during COVID-19. We're basically trying to see how can we reduce the burden of nosocomial infections, okay? After cleaning the theaters, after using the jig and whatever disinfectants that are there, okay, can we supplement this with the UV light, okay? Because in the European Union, they're really using this. We saw during COVID-19, Rwanda deploying UV robotic robots in their hospitals to actually be able to have this. So we've been able to team up, okay, with microbiologists, with also some clinicians, and then we put this to reality. But where the innovation is going, we are now moving from fluorescent tubes to now going into using LED light because of their power efficiency and so many other factors. Okay, so that's one of them. Then also there is a team that is trying to look at microfluidics, still around, okay, infections. Is there a way when an operation is going on, can we have a tool that within like 30 minutes, okay, can inform a doctor or a surgeon, okay, that actually a certain, or maybe the area you're working from is not actually sterile, okay? And one of the tools that can actually do this is basically the microfluidics. And we have this in our curriculum. This is still in the very, very early stages, but we hope in the future probably this project would come into play. The other is the gastro bag, okay? I know many people in the room have really worked on this project. The journey of this is it's a collaboration between Mark BME and Duke University. But we are basically using tools, okay, and resources that are around us. It's basically repurposing the urine bags, repurposing the O-rings in the female condom, okay, getting a flat iron, okay, getting a sewing machine, and we are able to have these designed in the makerspace that I showed you, okay, and the potential for them to be able actually to save lives, okay. So with this, apart from the bureaucracies, okay, and the need to actually ensure that it is manufactured under a quality management system, but most of the doctors feel like actually this should already be on the bedside to save as many patients as possible. Although now there are ideas. Hello?
1 minute.
Okay, thank you. Yeah, so box trainer, I know many of you have interacted with this. I'll skip that. There's also a surgical fracture table. Really, the surgery may not take place without having a surgical table. Okay, so the team with Western University in Canada are trying to see, can we reduce this cost? Okay, and we are basically using the open source platforms which are there to actually be able to have this. And this project is funded still by the government of Uganda through RIF. So we believe right now the team is now trying to have the actual product out. I'll skip the negative pressure wound therapy. I know Kato has talked about it. And yeah, I'll stop there for now. Thank you.
Thank you. You can have your seat. Yes, I like the idea that you took us through the process. For us surgeons, when we talk about innovations, we're focusing what's the process and what's the outcome. I'm sure you'll have some questions on that. Second last, our presenter will be Mr. Kenneth Nkwanji, who will present us to perceptions, attitudes, and barriers towards implementing virtual reality in health professionals, teaching institutions in Uganda. AI. AI is AI nowadays.
Good evening. I know you're expecting Mr. Kenneth, but I am Miss Deborah Chemtai Mangusho. Kenneth is unable to join us today, so I shall be presenting on his behalf. Yes. Yes. Is it me to control this? Okay, all right. So we did a study that was titled Perceptions, Attitudes, Barriers Towards the Implementation of Virtual Reality in Health Professionals Training Institutions in Uganda. Sorry. apologies, in Uganda. And my name again is Deborah Chemtai Mangusho, MBCHB5. Everyone has been displaying their credentials, but I don't think it's mine yet. MBCHB5, USCE, PLE, those are my credentials as for now. So yes, who has heard of virtual reality? Maybe just to wake the audience up. Yes, the doctor over there. You could just stand up, I think. Oh, you could tell us what you have heard of virtual reality. Okay, moving on. So the research team was Kenneth Chelimo Betoni, Asinja Arnold Bambale, and Chemtai Deborah Mangusho, and our mentor was Associate Professor Musime Victor, who most of you know. Yes. So virtual reality is basically this really cool system where you put on this set of glasses and you enter a world where you can feel and see. You're immersed in a different environment. So basically, it can be used in medical training. It has been used in like aeronautic engineer training, pilot training. It teaches them how to fly without the risk of actually injuring people or crashing planes. So in our study, we looked at what people perceived of using this technology in training health professionals. Yes. So the implementation of VR in medical training institutions has not been widely accepted in Ugandan institutions. We sought to assess the perceptions, attitudes among medical students and tutors as well as the barriers to the implementation through a qualitative cross-sectional study. Okay, so our objectives were again to assess the perceptions, attitudes, barriers towards the implementation of virtual reality in health professionals training. So the specific ones are there, of course, to assess the perceptions, the attitudes, and then the barriers. Yes. So we had the methods that we used. We used a cross-sectional qualitative study that was conducted at Makerere University, and our population was basically two groups of people. We had the medical students, which were MBCHB year 1 to year 5 specifically, and then we had our tutors. These tutors were handpicked either as recommendations from the students, or we saw that this person most likely has expertise in this area. So we collected a diverse group of tutors, and on these we conducted key informant interviews. Okay, so our selection criteria was this. We included, the inclusion criteria was the students pursuing Bachelor of Medicine and Surgery at Makerere. Then we excluded those who withheld consent and who are not at campus at the time of the discussion. How we sampled the student participants, we selected them randomly, and we selected 10 from each year. The lecturers, of course, have talked about how we handpicked them based on the recommendations. Yes. So our data collection, we conducted the focus group discussions, then we did our key informant interviews with lecturers, like one by one, and then all these we recorded on audio, kept the transcripts and transcribed them, and then sent them to the person for data analysis. Yes. So our data was analyzed thematically. We used an inductive approach. We first generated codes, and then from those codes we generated sub-themes, and from those sub-themes we grouped them into themes, and in such a way we were able to understand these perceptions, these attitudes, and these barriers. Yeah. So what were the results? So our results were that 17 themes arose from the study. So there were 10 perceptions, 10 themes according to in the perceptions, 5 in the themes, in the attitudes, 2 in the barriers. Yes. So I just want to define what we categorized as perceptions while we were doing this study. So perceptions, according to us, it basically encompassed the understanding and beliefs of health professionals and students regarding the potential of virtual reality in Uganda for their training. So it could be positive, it could be negative. Attitudes, basically, we looked at their feelings, their opinions, their dispositions, and how they felt towards using VR in their training. Yes. So in the perception, so of course, the students were very excited about it. They were like, it's going to improve learning efficacy. Once you see something, of course, I can't forget it. Once I touch it, once I display something, I can peel back the layers of the bowel wall, I understand it better. So they saw it as a means of improving learning efficacy. Of course, it would alter medical training in such that people were worried that maybe it could dehumanize care, like you're not going to exactly be with the patient all the time. So there's that potential of dehumanizing and depersonalizing care as well. And some people also thought that the learner involvement would not be as much, so it would affect medical training as well. And these are views and opinions from both the health professionals and the students. Yes. So students particularly, they said, we're familiar with similar technologies. We go for 3D movies, we see them. How far is virtual reality from that? We believe we'll be able to assimilate this faster and use this. So that familiarity as well. And the surgeons, of course, that we talked to, they mentioned that we do endoscopic surgeries, so it's easier for us to integrate this into our training. Then people recognize the economic aspect. To implement anything, you need funds. So, of course, the lack of funds would affect its feasibility, and if it's not feasible, it could just end as well. People raised the concern of it being sustainable. Then others also raised some necessities before we implemented this kind of study, virtual reality. So we need to train, first of all, the people who are going to train the trainers. Yeah, train the trainers train the students, and we also need like the physical space, the goggles. There's a lot of logistics involved in all this. So there's the need for financing as well, and also the need for human resource. We need IT personnel. Of course, they also thought about the negative impacts, like what will the seizure, when you're wearing these glasses, you're in a new world, so there's a chance that there'll be blinking lights. This could trigger a seizure for particular people, and also there's the concern of people with eye defects. Wearing these glasses could worsen that or affect them in some way. So there's also the concern of mental health. We all know that when we went into COVID, we came back feeling a bit shy and fearing to enter the sphere. Now you're taking us back to glasses. How is this going to affect people's interaction with their friends, their social lives, and their mental health? And what if people are doing the wrong things on the virtual reality? Yes. Then we also looked at the adaptability. Of course, people raised that the younger generation will be able to adapt to it faster, and the older people might push back a bit. They won't exactly be in par with this kind of training. Then there's also socio-ethical effects that were raised. In the socio-ethical effects, of course, our seniors were worried that VR, AI, these things are coming to replace us. So we could lose our jobs. Then ethically, of course, is the issue of data safety. So once you have something online, who is looking at it? How is it protected? How are people protected online? Then optimization as well was raised. This continuous feedback needs to be given so we can keep improving the system. So that was raised as well. Moving on. So
Deborah, I have 2 minutes.
The themes that were generated, people were optimistic about it. They were excited about the possibility of an improved learning experience. There was indecision as well. There was a negative outlook. Of course, we also saw that some people thought it would make students lazy with the tech. Tech could make students lazy, and the lecturers could also perceive it as spoon-feeding students. Like you're giving them everything they need. They need to struggle a bit so the information lasts and is retained better. So then they also said it should complement traditional training. It's a tool in the box, but not the whole toolbox. So VR should be an aspect of a larger form of training. Then there's that generational variation in attitudes, like I've been describing. The tutors we talked to were a bit hesitant. The students initially were very excited about it. Actually, we talked to a student and he said immediately, I'm ready to embrace this. Please bring it. So those generational differences in the generational variation in attitudes. We also saw a variation in sort of specialty, like the surgical tutors that we talked to vis-a-vis the medical specialists we talked to. The surgeons were more optimistic and positive about it. The medical ones were a bit more reserved and conservative towards it. Then the barriers that we came across, of course, the economic constraints, you need financing, and then adaptability constraints as well. Yes, so basically, I think as I was discussing, I talked about most of this thing. Unanimously, most people viewed VR as a positive way of enhancing learning, and financial constraints were viewed as the largest impediment to this implementation. And we saw that the older generations, including the lecturers and the administrators, they were less approving of it. Yes, our limitations were this study was carried out on such a small scale, so Makerere University is not a good enough picture for the rest of the training institutions. We know we have several other training institutions for medical students, and the fact that this was only carried out among students of medicine, of course, VR in medical training, of course it has to apply to the nurses as well, the radiologists. So basically, it was not expanded to that as well. Yes, I think I've talked about that. Of course, the blind and the dyslexic people, we didn't look at those as well. Yes, so what we recommended was that we needed further research in the implementation of VR in health professionals training, with a focus on widening the scope of institutions, courses, participants to adequately represent. So this is a blueprint for a future in VR in healthcare training. Yes. So institutions should provide support and sponsorship for wider research. So if you're here, yes, provide support. So in conclusion, the general opinion held by all participants was that VR is a crucial augmentation in medical training, worth consideration, and the plans to implement it, and circumvent or erase identified barriers. Yes. Okay, so yes, our study was funded by NIH. Thank you very much for listening.
Thank you, Deborah. That was a great talk. I don't know how many surgeons were able to give this talk when they had your credentials. That was really great. I'll just say that this is a great study. Probably when you're publishing, your mentors will help you in the methodology sections to make it stronger. Lastly, our presenter will be Rana, who will present to us awareness, perception, knowledge, and attitude towards robotic surgery among medical and non-medical population in Lahore. Is Rana around? Online? All right, we're unable to get Rana, so we'll take a few questions for the presenters. Christine, you have a question? Yeah, Dr. Namge and Christine. Let's move the mics around. We're running out of time. We'll take a few questions.
Thank you so much. Thank you to our biomedical engineering team. I'm very excited to have you. I was really impressed, and I'm very excited for the microfluids presented by Mr. Matovu. I think that will be one of the things that really transforms surgical care in terms of even just looking at surgical site infections and the cost that comes with when one gets a surgical site infection. So I really pray that project goes through and yeah, we get somewhere. So thank you for that innovation. I wanted to ask about the repurposing of urine bags for the gastroschisis babies. I recently got to learn that when you're repurposing anything that was FDA approved for a different purpose, you have to get new clearance to repurpose that. So do you have to go through that process, like at a national level and then probably at the African level? And are those things that could hinder our innovations? Like when we think of new ideas, like how people have repurposed different things to use, is it easier now here that maybe people are just not aware that they can actually legally sue us? By the way, surgeons, I learned that it's wrong that we even get that urine bag to repurpose it for like gastroschisis, or let's say you fail to close the abdomen and then you use it as your Bogota. If you are sued, you can actually legally be sued for that. Yeah, yet it's an improvisation that's actually working. So maybe your guidance on how you're going about that. The other thing was about the key loop. It's something I've seen around, but I wanted to ask about, one of its side effects is usually the traction ischemia. How has the device been able to kind of factor that in? Or does the surgeon have to do like how we usually pause for the, when we are using gases for the pneumoperitoneum? So now for the traction, if I'm doing a longer surgery, and remember when you're just doing traction, your intra-abdominal space is reduced. So also those things of risks of having more injuries is higher because of your reduced visibility. But just for the traction ischemia bit and also increasing the field of view, how have you managed to do that? Thank you.
We can take one more question. Yes.
Thank you so much. Dr. Ampire Duffin. I'm a pre-intern. I volunteer at CIS Hospital. And my question goes to Deborah. So I'm very excited about what you've presented, and it's amazing. And I'm happy that Dr. Leo is here, and then he could also supplement on this. So what is your plan about the data colonialism that is going to come out of all this? Because we are having AI on board, but our data is going out there. You put something on Meta, someone out there is reading our information. So there is a lot of data colonialism that is going to come out of this. And what is your plan about that? What were your measures about that? Thank you.
We can get presenters respond to this before we take maybe one more round of questions. Yeah.
All right, thank you, Dr. Christine, for that question. Yeah, repurposing, it all goes back to the medical device definition, okay? The definition of, for you to say, my product is a medical device, the manufacturer has to put that claim that I'm manufacturing a medical device. Now, the manufacturer of urinary bags, okay, has an intended purpose and use, okay, that's submitted to the regulator. If you repurpose that, okay, for another function that the manufacturer has not intended, all the risks that will happen will go to you, okay? If that happens, okay? So anything that will go wrong by you altering what the other manufacturer has done, okay, will go to you, because the intended purpose and use of the device, you've actually gone, okay, away from what the initial manufacturer has done. But here on the gastro bag, what we were looking at was mainly which materials are close to us. One, to prove the concept that this can be done. Now, where the project is going, because we can't continue buying the urine bags, okay, and repurposing them, plus the female condoms. But one of the challenges was, even in Shauri Yako here in Kampala, we struggled to look for the original Some from China, because of the we have to buy solution, okay, to the current stage, okay, would okay for it to be out because is supposed to go through. But however, so these are some of the challenges that hinder the innovations. Is you have a totally new device you want to push on the market, but however, the regulator doesn't have something to learn from. Plus also ethics is asking you for a certificate of good manufacturing practice. Yet in the country, in the region, there is no company that has a GMP for manufacturing medical devices. Then the recommendation is go to India, go to China. Then when shall we develop locally here, okay, to have this? Can they give Makerere, okay, maybe a certain certificate of compliance to see that devices can actually translate quickly to the market? Instead of setting up, she talked about Shishi International in Namave. We've invested a lot in Shishi International to get the GMP. Hopefully, other innovators will have a bit shorter time to get approvals from NDA to have their device go out. So it's multi-sectorial approach, okay? And we need all stakeholders to come on board on this. But my recommendation is it shouldn't be, okay, taken out unless it has gone through the necessary approvals. And one of them could be an ethics clearance for it to be tested, okay? But we know it works. The surgeons are happy to have it out, but however, there is no regulatory support behind the product. That becomes an issue, okay? But we are using a material that is biocompatible, that we already know, okay? All this information is available, but we can't always continue to buy from another product. We need to get our own supply of raw materials. That is something the team is trying to navigate. Plus also, how are they going to manufacture? They need to create a manufacturing plan for all this. And each of those stages has to be approved by the regulator. So these are hurdles that take months for NDA to say, now this stage is okay, this stage is okay. There are gaps in this stage of your packaging. Don't continue. We need to also verify this packaging. And that's what is being done at Shishi. Hopefully, the gastro bag in the near future will also be taken on by Shishi once it has been approved for ethics clearance for its trial to take place. Thank you.
So thank you, Daphne, for your question. So my response to that is you asked about data colonialism and how participants' data would be protected and whatnot. So about that, in our study, it was a concern that was raised. They raised the concern of data security, but in case it does pull through and an institution manages to put up a VR facility, I guess there will be cybersecurity experts to take care of that, but we did not put in much consideration, but I think it's a very valid concern. Thank you.
Okay, I am going to do my best to respond to Dr. Christine's question on the key loop, considering I'm not a surgeon. But after this, I will refer you to the surgeons on the team so that they can give you more comprehensive feedback. So the key loops, in part of the design criteria, we considered the varying abdominal masses. Different people have different abdominal masses, and then calculations were made on they have circular bases on what diameter would be appropriate for a given range of mass. And the way the gas will, when you retract with the key loop, it will form a cone. But when you retract with gas, it's more spherical. So they put all those considerations in place. There's a publication, I can't remember the exact numbers, but that was trying to take care of the field of view, trying to make sure there's enough space. And then the tip of the retractor, just as you're trying to enter, we try to make it as smooth as possible to prevent injury. I don't know if I am trying to respond to your question. Yes, I think those are our considerations. I am not a surgeon. I don't even know what ischemia is, but I will definitely get you in touch with the surgeon. Thank you.
Thank you, Paula. We'll take one more round of questions, then close. Yes, Dr. Chigonya.
Thank you very much. Thank you to the presenters, Dr. Chigonya Victor, Chibuli Hospital. So my question goes to I think the person who talked about negative pressure device, locally made.
Yeah, right.
He talked a lot about cost. I want to know if he considered the fact that this device has accessories. Usually, on every dressing change, you need to buy new accessories because they have been used up. Maybe you have you still use the same machine if it is not the disposable ones. Those accessories are quite expensive. I don't know if you are planning to locally make them because most are sponge and we have royal foam here. So I don't know if you are going to use royal foam. Then the lady who was talking about the loop, I think I missed the question from Christine. I also wanted to ask about that retraction or for long surgeries. I don't know how sustainable it is. And it becomes very dangerous when the retractor is not doing his job. He starts abusing everyone, the instruments start falling. So if retraction becomes a problem with that device, we may be in problems. Yeah. I think you need to consider that. And why did you discard carbon dioxide, which is free in the atmosphere, and look at the loops? Then the lady Chemtai who talked about virtual reality. Why did you think that, how will it change surgical care if we put it in context for today? If we flip abdominal wall layers virtually, will it increase the chances that I will pass my incision through the midline compared to if I didn't flip through the layers virtually? Thank you.
Thank you. There's another question. Then we'll have one more after him.
Thank you very much. My name is Dr. Titus. I'm a plastic surgeon. Mine is not really a question, but I just wanted to say thank you to the biomedical team. It's exciting times to have young men and ladies really trying to do something for our country. I just wanted to say that Ethiopia is doing a lot of things that are being discussed. Ethiopia had issues with the international community. So they had challenges with supplies and they began improvising. And I think for us as a country, we're a bit lucky that we have supplies. So I'm really so grateful and happy to see this, and I hope that you continue building on it. It's really a comment. Thank you.
Thank you, Dr. Pego. I fully agree with you. Yeah, one last question from Dr. Kasaga Brian. I don't know if he wants to answer or he's answer a questioning his research team. This will be, for the interest of time, Dr. Kasaga's question will be the last one. You can ask the discussion after here.
Yeah, thank you so much. Interesting project, Deborah. I wanted to find out in your methodology, did you look at it in terms of just studying anatomy, or you looked at it in terms of preparation, for example, for a surgical procedure, like a simulation? The other team, the biomedical engineers, are also doing some work. With that, they create models that you can train on for surgical procedures. I don't know if you only looked at it in terms of just education, but also the other aspect of simulating surgical procedure. Thank you.
Thank you. Could you please respond to those in no order to those questions and concerns?
I will go first. Thank you so much, Doctor. So I did mention the issue of cost, and accessories are part of a system that we are developing. So in development, we first, if we look at the entire system at once, we may end up not getting the results that we need. So we first looked at the device itself. What are the things that make the device expensive, and what alternatives do we have? So a similar approach is what that we use to look at the accessories themselves that are used for the wound dressing. So the team will be dedicated to look at the accessories, how best can we reduce the cost. This cost at times, it comes up with a supply chain. Things are being manufactured in, say for example, in China, and by the time they reach to Uganda, the cost has gone up like 15 times. So if we navigate that supply chain, we can be able to reduce the cost. Or if not, we can get alternatives that are being manufactured by in-house companies in Uganda. We are also, as Paula mentioned, we are working with Shishi International to get the accreditations. So there will be a strong arm to be able to help us to manufacture different items within the country. So we hope it will be reducing the cost as well. Thank you so much.
Okay, I am going to respond to the question about the KILUP being a replacement for carbon dioxide. I wouldn't call it a replacement, it's just an alternative. So in cases where the carbon dioxide is unavailable, we are just trying to provide an alternative, that's all. We know we all breathe in oxygen, but if you went to a hospital, you might not find the cylinder there, yet it's freely available in the environment. So just trying to get a cost-effective alternative.
Thank you. Thank you, Dr. Brian, for your question, and the other doctor. I think I can answer both questions together because I feel they're related. In interest of that time, I think I didn't use as many examples as I could, but yes, we did look at it in the context of surgical training. We actually, when we were talking to our key informants and the people for the focus group discussions, we explained to them that you could do a surgical procedure as many as 50 times and practice it, so you have mastery. This is the layer. First go through the next layer. I don't know much, but yes, you can do it as many times as you want. You can practice it and then go apply it onto a patient. I think that's also how it can apply in, how it can improve surgical care in Uganda. We can train better surgeons and eventually improved healthcare outcomes for the patients. Yes, thank you.
Thank you, our dear presenters. I must say, this guy is amazing. They are young people who work with great mentors. I haven't known some of the lab leaders, so if you have any other questions, you can ask their mentorship team. But thank you all for what you're doing. I think you're going to be great researchers, so thank you all. Yeah, with that, I think we have come to the end of this session. I'll hand over to Dr. Kangulu. Thank you.
Stay behind for a photo. Thank you to our team of engineers and biosurgical engineers. They are more surgical than medical. All right, so we have come to the close of today's program. We'll perhaps have a closing prayer, and then we'll continue with the scientific conference and the exhibition tomorrow and on Thursday. I want to appreciate everyone who has been able to make it today, despite the heavy downpour in the morning. And I want to implore you to still come in as early as possible. Tomorrow's program will begin at 7 a.m. And when you travel early, you can beat traffic to this place. So thanks, everyone. I'm going to ask Flavia to give us a closing prayer, and then we can still go into the tent and greet, as there are still some people there waiting for us to look at the exhibition, and there's evening tea as well. Thank you.